obviously he need to talk a lot. So that's a very important history. That means he's actually putting lots of effort into the voice, and that may be one of the reason. And how often how he work every day is a week?
हर रोज काम करते हैं आपके? So he works every day.
7 days a week.
7 days.
6 days a week, and how many hours every day?
कितने घंटे बात करते हो? 9 से from 9 to 10 hours he is.
So you can see that itself is a big issue, because a normal person, the standard dictum in laryngology is that for 1 minute voice you need 2 minute rest. That means 8 hours voice and 16 hours rest is the standard thing. Now this man is actually working 9 to 10 hours, and forget, he has to go to his family, he has to talk to them. So that means that the ratio itself is troublesome, and he's working 6 days a week, has been that. So obviously there is a thing, a recipe for voice problem. So we will see how thing. Now just before doing the scope, we will just see any other comorbidity for him.
कुछ और sugar, diabetes, इसके अलावा कोई? He's a diabetic.
He is a diabetic. That's the only thing, right?
Blood pressure. Normal. Check करवाते हो? No hyper, not non-hyper.
He is a diabetic. And do you smoke or drink? Smoke?
Smoking के drinking?
When did he stop? Oh, he was a smoker, and so then that adds a dimension little bit different. When he's a smoker, you also have to keep it in mind. So here, when you have got a scopy, it's very important. It is not, I will say it is not a must, but it is preferable to have an NBA with you, because that will give a better result. Now, before doing the scopy, one more test, that is the maximum phonation duration. You just ask the patient to take deep breath and say E, or any vowel. E is the easiest, for as long as you can, in your normal speaking pitch and loudness.
आप ना एक लंबा सांस लीजिए और ई बोलना है आराम से, जितना आप अपने बोल सकते हैं.
It's only 6 seconds, very rough voice, breathy voice. So that is much about the history. In the neck, it looks fine. There is nothing wrong. You can also palpate for any tenderness. Usually people with the vocal nodule will have a lot of tenderness over the hyoids, and people with the ventricular band will have pain over the thyrohyoid. So nothing there. I'm going to do the scopy now. Give me the scope. This is a NBA scope or a plain scope? NBA scope is there. And but strobe? Strobe also is there. So keep strobe also. Oh, you have to. It's a new type, Everything is there. Okay, the same scope. Yeah, I know. Okay, right. Okay. Yeah, where is a ghost piece? Weight balance. Yeah. Okay. Yeah, jelly, please. Oh, you haven't. Okay. Okay, fine. Okay, I'm going to do the scopy. So go through the nose, whichever side. This is a small scope. How much is the diameter? 3.2. 2.6. Oh, it's small scope. Wonderful. Okay. So I'm going along the floor of the nose. Ask the patient to breathe through the mouth always, because if they breathe through the nose, it will get.
We do not see the screen. Monitor we want to see.
You will get it. Now ask him to breathe through the nose. He is going back. Don't go back. Yeah, right. Okay. Are you getting the picture now?
No, sir.
Ask him to swallow.
Please arrange the trolley so that we
Ask
can
him to
see.
swallow. Yeah, right. Okay, that is okay. One is enough. Enough. You are not getting the picture. Okay.
The trolley can be moved.
They are giving from the other.
Digitally be honest. Yeah, now we can see.
You are getting. Okay, ask him to swallow again. Yeah. Okay. That is okay. Now I am going near, so you can see ask him, say big 2 polyp. Can you see that reddish polyp?
Yes.
Both on the right and left. It is actually an asynchronous polyp, you will say, but that means at a different level. Right. The right one is more anterior. He don't swallow this much. He is actually keeping on swallowing. Cool down, cool down, cool down.
आराम से
Now swallow again.
एक बार इस गट को
Ah, yeah, right. Enough, 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 enough. Enough, enough. Don't swallow now. We can see that now. Yeah, the reddish polyp. Can you see that? Hello,
Yes,
Sanjay?
sir.
You can see that, no?
Yes, sir. Very nice.
Yeah, now I will put the NBI. Put on the
On
NBI.
bilateral vocal cords.
Press it, I can. Yeah, now you have got the NBI mode. And go near to check whether there is anything suspicious. This is typical of a hemorrhagic polyp. Uniform bluish color. There is no prominent capillaries, no capillaries across the long axis of the vocal cord. So nothing to say. This is totally a benign looking thing. Swallow again.
Sir, for the sake of PGs,
Yeah.
what really do you want to see in NBI?
In narrowband imaging, especially you are looking for a tumor. If you are
Yes.
getting a case, I will show you that there is what is known as small, it's like a punctate blood vessels. You will see multiple hairpin blood vessels and blood vessels at perpendicular to the long axis of the vocal cord. They all are signs of suspicious sign. But here this is all complete bluish. So that means it's only blood. There is nothing to suggest any pathology here. That is a normal way. Now, if you look carefully, you can see that. Can you ask him to breathe, swallow again?
एक बार गट को भैया एक बार हाँ शाबाश गट को एक बार
Yeah. Right. One is.
बस ज़्यादा नहीं
Okay. Now I will go very near the vocal cord. You can see some blood vessel over the right vocal cord. Can you see longitudinal vessels? Longitudinal. Can you see small blood vessels there? On the right side, see that very,
Yes, sir.
yeah, they are normal. But when the blood vessel is like in at right angle, going across the infraglottis and hairpin loops, they are all suspicious. When we get a case, I will show. But this is normal. So a blood vessel, normal blood vessel, unbroken blood vessel in the longitudinal axis of the vocal cord is a normal thing. But when they are broken, they got multiple, at hairpin bends, which go sometimes into the perpendicular to the long axis of the vocal cord into the infraglottis, then that is abnormal. This is a normal. You can see both masses are uniformly bluish, so that just suggests it is only blood. So this is a hemorrhagic polyp. There is nothing to suggest any malignancy here. He should be okay with a proper surgical removal of both these conditions. But why it precipitated? Here's his job is very troublesome. So he has to be counseled how to avoid all those things. I don't know whether he need a microscope. I don't know to whom, how many people he talk at that time, how much rest he take. But 9 hours a day is actually a problem. So we'll have to tell him that this is your job problem creation. And luckily he has stopped smoking. As of now, there is nothing to suggest, but still, when we do the surgery, we will send for biopsy, but 99% it is, I'm sure that is only a benign lesion.
Do we have to follow any classification for NBI?
Yeah, there are two kinds of classification. They are very, literally very complicated. Knee classification and the European Laryngology Society. So what most laryngologists will do is that for documentation purpose, they will actually take a copy and print on the thing because it is such a complicated thing. But what is easy? They remember two things. When you see a broken blood vessel, today you saw a very longitudinal intact. When you broken and it has got lot of angle at 90 degree, it go perfectly at perpendicular to long axis. When there is clumping, like when you used to do the hemolysis, get the clumping. Similarly, if you see clumping, they all are signs of pathology.
Sir, as the lesion is on both the vocal cord, so we can operate simultaneously, or we have to operate first one side, then on the other side?
Very important question. An experienced person can actually operate bilaterally. What is important is that the anterior 3 to 4 millimeter is very important. So what happens is that many times, because all these lesions are very fragile, so what happens is that when you catch hold of one polyp and try to cut, what will happen? It will avulse the anterior one side. And if it happens on both sides, it will invariably result in a web. So the simple step which will prevent that, before catching hold of the polyp, you put a small cut at the anterior end of the polyp. So even if it avulses at that end, that it ends there, so that the anterior view of the anterior commissure is not damaged. So it is very, very important when you do a bilateral surgery, you make with your knife, laser, scissors, whatever it is, that you make a small cut at the anterior end of the polyp, where it join the vocal cord. So even if it avulses, it will actually avulse then and there itself will come out. So that anterior V won't be there. But if both anterior V, both part it is avulsed raw, it will end up in a
Web.
in a web. If that happens, unfortunately, and you don't have any other facility to do, what you should do is you should inject Botox bilaterally into the thyroid node, so that the adduction will not happen. So then that will actually prevent a web formation.
Right. Thank you very much, sir.
Coblator, I don't like coblator at all for a phonosurgery. It is a wonderful equipment for airway and other thing, for a live for the phonosurgery, because coblator there, however careful you may be and however smaller may be, there will be some collateral damage. So the best equipment will be either the cold instrument or the carbon dioxide laser.
So the next patient which we are taking is Mr. Ghosh.
Yes.
He has got a big glottic chink, and his endoscopic report is there, but he is not able to produce adequate throw in the voice.
What is his problem with his leg?
आपको ये पाँव में क्या हो गया सर? फ्रैक्चर हो गया सर इनको.
This is after an accident.
ये आपकी जो आवाज कैसे खराब हुई?
आवाज निमोनिया से क्या है? निमोनिया हुआ था.
इनको he has got pneumonia. After that his voice is like this.
And when was that pneumonia?
1st of August.
Oh, this August only. So that means it is only 1.5 months before. And was that pneumonia very severe?
Yeah.
And were you intubated? You were on a ventilator.
No. No.
You were not on a ventilator, but you were in the ICU.
I was in ICU.
But they didn't put any tube or anything inside your mouth. Nothing. Nothing. Oh, but still you lost your voice.
Yes, I was on high antibiotics.
Oh, okay, okay. So his history is that he had 6 months back, 6 weeks back, he had a pneumonia, fairly severe. He was admitted in the ICU, but there is no history of an intubation or a tracheostomy. Then he came out of that. Then after that, he has got this big voice problem. Have you got any problem with eating and drinking?
No.
Do you choke on taking water, liquid? When you take liquid, do you choke?
Yeah.
Yeah,
पानी पीने में ठसका लगता है आपको?
So I didn't see it.
yeah, occasionally he chokes on liquid. So that two symptoms go hand in hand. When somebody has got such a breathy voice, and when somebody say that there is a choking with the liquid, you should always suspect that there is the vocal cords are actually not meeting perfectly in the midline. There is a big gap, so that when he is swallowing, the liquids will go semi-solid, will not actually create much problem. And any problem with the breathing?
I'm bit asthmatic.
What did you say?
I'm bit asthmatic.
Oh, you are a
He's
non-asthmatic.
asthmatic.
Are you on an inhaler for a long time? He is not an inhaler, but right now you don't have breathing difficulty.
No.
No. Any other illness you have got? High blood pressure, diabetes.
BP is normal. Yes.
You are on medicines,
I am on medicine.
but no diabetes, no cholesterol, no thyroid problem, nothing like that. Are you allergic to any medicine?
No, sir.
No. Do you suffer from acidity, the gas problem? No. Do you smoke or drink?
No.
And what is your job?
I was with Lupin Pharmaceuticals.
You need to talk?
I was with Lupin Pharmaceuticals.
Yeah, what I'm
He was
saying
with
is,
Lupin
do you
Pharmaceutical.
need to talk a lot for your job?
No, I have retired 10 years back. I'm 71.
Okay. How old are you now?
71.
Okay. And what happened to this? This is an accident.
This, I just fell down from the chair.
When?
This is hardly 7-8 days back.
And what did they diagnose? Is it a fracture or something, or a sprain, ligament sprain?
Metatarsal.
Metatarsal fracture is there, so they just keep it. Okay. So that is a history. So main thing is that his voice is so breathy, we can't even hear that. How is your cough? Can you cough a little bit? Now there is voice. That actually doesn't.
समटाइम्स आवाज निकलना शुरू हो रहा है.
Sometimes it comes. Now, can you imitate a lady voice like? See that the voice is coming. Now, can you imitate? Can you produce a voice on inhalation like invade like? See that? So these two things suggest that vocal cord structurally is fine. That medial margin of the vocal cord is fine. There is voice. But somehow it is not coming close to each other. Why it is not coming close to each other? We will see. Yeah, please I spray his nose. I'm going to be careful. Yeah, this little bit stinging spray for a minute after, and it is through the nose. So nose only. For a minute it will be uncomfortable, but then it is okay. That is the only difficult part of this procedure. That's all. Now scopy won't be painful. Don't worry. I will don't use it because I am scared of injuring your leg. I don't want to do that. Yeah, put. Jelly. So we are just going to, I'm going to see through your nose. Okay, it won't hurt, don't worry. I will be going through the nose only. You breathe through your mouth. Keep the mouth a little bit open.
Endoscopic picture, please.
So I'm going
Yeah,
through,
it is there, Sattu.
I'm going through the nose now. Yeah, reach the palate. Now once you reach the palate, ask the patient to breathe through the nose.
नाक से सांस लीजिए सर.
Yeah. Now can you swallow a little bit?
एक बार थूक अटक लीजिए.
Swallow once again. Once again. Swallow. Yeah. Tip of the scope is not okay. Let me get it. Swallow once again. Okay, say no. I'll take out the scope and clean. It's not clean. Yeah. Yeah, now breathe through the nose. Swallow now, saliva. Right, that's okay. That is okay. Say, swallow once again. Say, if you can see that, now you can see that that is a vocal process. At the vocal process level, it is meeting very well. Say, can you see that posteriorly it is meeting? Can you
Yes.
see that? But
Yes, sir.
anteriorly there is a big phonatory gap, especially on the right side. It is so much of bowing of the right vocal cord is there. It is actually the right. Left is not that bad. Left is fairly straight, but the right is bowing. Can you see that? Can you see the bowing of the right vocal cord now?
Yes, sir.
Yeah. Say, see that? And
Yes.
he is trying to compensate with two methods. One, he tried to compensate with a ventricular band, and also he tried to compensate gap with the epiglottis going backward. But vocal cord movement is normal, but he has got severe atrophy of the vocal cord, especially on the right side. You can see that the right vocal process is very prominent. There is a bowing of the right vocal cord, but movement is normal at the level of the arytenoid, say, at the level of the body of the arytenoid as well as at the level of the vocal process, it is normal. So that means interarytenoid and thyroarytenoid are okay, but his thyroarytenoid is very, very weak on the right side, especially on the right side. Swallow once again. Once again. So you can see that. See that? Now I will ask him to produce a baby voice, female voice. Say ee. Ee. You can see it little more better, but you can still see the arytenoid, the epiglottis is trying to compensate, the ventricular band is trying to compensate. Ee. Can you see that? Ee. Now I will just put the strobe on. Is the strobe on? Continuous E. Because the air leak is so much, there is very little movement there. That is why the strobe is not picking up. Say E again. But you can see the right vocal cord is bowed too much. E. Left is fairly okay. He has got a right vocal cord bowing. E. But at the vocal process level, you can see that vocal process is meeting perfectly. Can you see that?
Yes.
Yeah, but the anterior two-third, that is dependent upon the thyroid node integrity. So his right thyroid node is very, very weak and left is okay, right. So we have to assume that this was actually a post-viral thing. In the first history, I thought, because of the intubation or something, he developed a voice problem. His joints, so what are the good things about him? Joint is intact. Vocal cord movement is normal. The problem is that the right vocal cord is very, very atrophic. He is a non-asthmatic, but he is not on a regular inhaler. Inhalers, that steroid inhaler can produce bowing of the vocal cord. So hopefully it should actually recover in a due course of time. But his voice is so bad, and if he is very particular, so there will be 3-point team. 3-point treatment for a vocal cord atrophy or paresis. One is you give a neurotropic agent like Neurobion or Renerve. Second is the voice therapy. The specific voice therapy is known as the half swallow boom. I will actually show how it is to be done in a unilateral vocal cord palsy. And third is that for immediate injury, if he actually is one of the best candidates for injection laryngoplasty, because you expect a recovery. In the meantime, you can actually bulk up the right vocal cord by doing an injection laryngoplasty as an outpatient procedure. It will actually become better. The voice will become better. The strain will become better. For recovery, we will teach him the half swallow boom, and also we will give Renerve. That is a plan. So in 6 months' time, the Renerve, the injection material will stay there for 6 months. By the time I expect him to recover, because all the other branches are normal, all the other muscles are normal, he should recover. If it doesn't recover, that is a very unlikely thing. At the end of 6 months, his voice is still bad, then he need a bulking up surgery.
Any role of swelling test in such a patient?
He doesn't have a swallowing issue, right?
Good morning, sir.
You didn't have?
During this pneumonia,
Ah,
I was given inhalers for that period.
Also down.
No, but
it's actually long-time steroid inhaler only will produce a vocal.
I will ask him whether if he is ready.
He's
then we
ready
will
for
take
injection
afterwards.
laryngoplasty, we can do
We
that.
can do it.
Otherwise, we will just give the Renerve twice daily and also the half swallow boom. If the people want to see, I can actually show it. Now, give me a little bit of water. 5 ml of water. Now, previously, for a unilateral vocal cord palsy, there is a phonatory gap. The standard treatment, standard voice therapy was known as the push-pull technique, which is actually not a very good technique nowadays, which actually create lot of problem for the patient, because he will develop unwanted compensation like ventricular band. Already he has got that. So push-pull means, you can see me, no?
Yes, sir.
Yeah, push-pull means you can do in different way. Maybe you can sit on the table like that and putting your resistance like that, then like that. So you know that when you do it, actually the hemilarynx come close to each other. But there is a problem. If you are not compensating it very well, if you are not supervising it very well, many patients will actually develop ventricular band compensation. This is worse than the primary condition, and he already has got ventricular band. We don't use it. So right now, what is known as a half swallow boom means you actually elevate the larynx. In swallow, the larynx elevate, and when the larynx elevate, vocal cord come close to each other and then produce the phonation. This will actually close most of the gap. One of the easier technique is actually this is my own modification of the half swallow boom, because the classical half swallow is very difficult. In textbooks it is said that ask the patient to initiate a swallow, At the middle of the swallow, hold the larynx in that position and then produce a low pitch voice. That is why it is known as half swallow boom. So it is like the classical half swallow boom will be, I am trying to watch my larynx. I am trying to swallow. At the height of the swallow, I will hold it and then produce a sound. So it is like, can you see that? Larynx going up.
Yes.
But most people won't do that. It is very difficult. So I have designed my own technique. This is actually a very easy technique. You ask 5 to 10 ml of water in the throat, keep the water in the throat and then produce both gargling as well as vocalization. So everybody will be able to do that. It is like this. Watch, when I do that, also watch my larynx, it will go up. And the biomechanics of larynx is such that when the larynx goes up, vocal cord come close to each other. So it is like, did you see that? Watch my Adam's apple. This is actually a very simple technique. Most patients, but mind you, this can correct only a 3 millimeter phonatory gap. If the gap is very big, none of the voice therapy will work. But a small gap will always be corrected with this technique.
Even if any patient is coming to our OPD which has got a glottic chink of a small size, we can this half swallow boom.
Because why it is known as boom? Half swallow means you are elevating the larynx. And laryngeal biomechanics has got another rule. When the larynx goes up, the tendency is for it a higher pitch. So, like that. So to counteract, you intentionally produce a low pitch boom voice. That is why it is known as half. You are elevating the larynx, but you are very particular that you don't produce a very high pitch voice. For a male, that is not acceptable. So there is no, if I produce a falsetto, the larynx will go up. Say like, see the larynx going up. But that is not good enough for a male. So we teach elevate the larynx and intentionally produce a low pitch That is why it is known as half swallow boom.
Okay. Because we see a lot of patients like
3 millimeter gap, it will actually do very well. They will actually clear.
And for how long we have to?
Usually in few weeks, 2 weeks time, they will actually learn the voice. The correct voice will come back.
Okay, sir. Thank you.
If they do regularly.
Next patient.
Sir, in this case, one vocal cord was weak.
Yeah.
This patient.
Yeah.
The left one.
The right one.
Right.
The right was bowed. Left is fairly straight. So we will inject more on the right side. 1 cc of hyaluronic acid should actually do much better.
Okay, sir.
Hello. Can you speak English? Yeah, okay. Tell me your name, please. And how old are you?
You give her the.
Yeah, she's a 64-year-old lady, and tell me your complaint. I am Dr. Jayakumar. I am Dr. Jayakumar. You can tell me your complaint. What is your problem?
Doctor, about a year ago underwent total thyroid.
Okay.
But before the surgery,
Ah,
I had started experiencing voice.
She has shown you online. He is the
Yeah.
patient of Dr. Divyasheel.
okay, okay. So 1 year back you underwent thyroidectomy, and what was the biopsy report of thyroid?
Papillary carcinoma.
Papillary carcinoma
Papillary
thyroid. And did you
carcinoma.
undergo radioiodine therapy after that?
Yeah.
How many doses? 1 or 2?
One.
1. And how much thyroid you are on now?
I was on 100 mg.
Right. Are you on a calcium supplementation too?
Yeah.
How many calcium?
1,000.
1000. That means 2 tablets of Shelcal you are taking every day. Is that right? Yeah. Any other illness you have got? High blood pressure, diabetes? Nothing. You are otherwise healthy. Do you have got a specific job which involves talking or anything like that? Or you don't have a special job, something
I
like
was
that?
just fond of playing the piano and singing. That's all.
You are fond of singing, right? That is a major issue, right? So you can't sing it anymore now. Is that right? Okay, don't worry. Okay, we'll try to find out a way. Now it is 1 year. Is that right? Right. And is your voice better in the morning?
Yeah. It's significantly better in the morning. But as day progresses.
Yeah, that's a typical history. When a vocal cord palsy happens, the voice will be much better in the morning. When they take after a good rest, they will voice be better. But as the day progresses, their voice become bad. Okay. Have you got any problem with eating and drinking? Yes.
When after a meal, I start getting a reflux.
Yeah. Do you choke when you take liquids? Say like thin water or
No.
No.
But I've developed a practice of sort of sucking the liquid.
Ah, right. You had problem in the beginning, right?
In the
Yeah, that is again a typical history. A vocal cord palsy, an acute vocal cord palsy will have some problem when they take liquid, but she has overcome with that. Are you short of breath or something like that?
No.
No. And can you take a deep breath and then say E for us? I will explain it. Normally, when the both vocal cords are meeting, usually most people can go up to 10 seconds. Like I will demonstrate how it is done. So take a deep breath without wasting it. Go on saying E like that. I will just demonstrate. It is something like E. I can go for say 20-25 seconds, but at least 10 seconds is the minimum. We'll see how much you can go. Please do that. 5-6 seconds. Anything else you noted other than that? Do you think that this is your original voice?
No, doctor,
No.
it's a very high pitch.
Very high pitch. That is a normal compensation. We have seen that. When there is a phonatory gap, you elevate the larynx, you get a closure. So this is known as paralytic falsetto. Many people, without knowing them, develop a compensation by elevating the larynx. So the gap will become less. So this is the typical case of a paralytic falsetto. She has got a paralysis. The gap is there. So she is trying to compensate without anybody telling her. That is a nature's response. So this is elevating. So the pitch goes up. That is why in half swallow boom, you tell them, elevate the larynx but try to produce a low pitch. This is a typical natural response to a unilateral vocal cord palsy. So she has got a unilateral vocal cord palsy. You know that MPD is only 6 seconds. She has got a high pitch sound. And she is really bothered about singing. So you don't sing at anything at all, not even one line? You can't. But you would like to.
Yeah.
You try one line.
Just one line?
No, I can't.
Okay. Don't worry. We can actually make you sing again. Don't worry. I will do a scopy now. Right? Just spray something. I am going to spray your nose with this spray. This is an anesthetic spray. For a minute you will feel stinging, otherwise it is not painful. Don't worry, be relaxed. It's a very small procedure, 1 minute only, okay? The spray is little bit stinging for a minute, then you will be okay. That is the worst part of the scopy. Difficult part is over, you will be okay now. You will wait for a minute and then do the scopy. So that's a typical history of a unilateral vocal cord palsy. And mind you, she also told she had some voice problem even prior to surgery, and even before surgery you had problem.
The cancer infiltrated my...
The nerve.
No.
So it is quite possible that at the time of the injury itself, at the surgery itself, her vocal cord was damaged. Right. Now we will see what we can do and how. Can you put a jelly, please? So this won't hurt you, don't worry. Okay, just relax. You breathe through your mouth, I am going through your nose, okay? You keep on breathing through your mouth. You can see the palate. In this case, you don't expect any palatal palsy, so I am not testing because it was a thyroid surgery. Now breathe through your nose. Breathe through your nose. The first thing you see that left arytenoid is falling anteriorly. Can you see that? Left arytenoid doesn't have any tone. Can you see that?
Left is holding.
Left arytenoid, can you see that it is falling anteriorly?
Yes.
And the right is moving. Say E. Say, swallow once again. Swallow. Okay. Say the right is moving, but there is a very, very big gap. See that the left vocal cord is
Yes.
bowed and left arytenoid doesn't have tone. Swallow once again. And right is trying to compensate. Say E again. This is known as the overriding of the arytenoid. The right arytenoid is overriding, and also see other compensation. Right false vocal cord is coming into play. E. Can you see the right false vocal cord meeting?
Yes.
Yeah. So she has got a left vocal cord palsy. There is atrophy of the vocal cord, bowing of the vocal cord, big phonatory gap at the anterior two-third as well as at the vocal process level. Left arytenoid is falling anteriorly. Right is trying to compensate by overriding, and right ventricular band is trying to compensate. So that is almost like a total, all the muscles of the left vocal cord is gone. Thyroarytenoid is gone. That is why the anterior two-third phonatory gap. That is why the bulk is not there. That is why the tone is not there. Lateral cricoarytenoid is gone. That is why there is a big gap at the vocal process level. Posterior cricoarytenoid is gone. That is why it is not abducting. More importantly, posterior cricoarytenoid also has got a major role in holding the arytenoid onto the cricoid. Now the posterior cricoarytenoid is completely gone. That is why the arytenoid is falling anteriorly. Only interarytenoid has got intact. That is why there is no gap at the body of the arytenoid level, because interarytenoid has got bilateral supply, and she is doing her best to compensate by doing a right overriding of the arytenoid. Now it is 1 year. Realistically, there is no chance of it recovering now. Right. Now she wants a voice. She is 64-year-old lady, no other comorbidity. There are two ways of bringing back the voice. One is a static procedure where you do actually a thyroplasty plus an arytenoid rotation. So you actually make the straightened arytenoid, bring back the left vocal cord into position and get a voice. For an ordinary person, if he not more important, not insistent on singing or anything, I will actually go for that. But she is a singer, and I can see from her face she is very sad about not able to sing. So I will always give her option of non-selective reinnervation. She is actually the candidate for non-selective reinnervation. So what I will personally do is that I will do a non-selective reinnervation, but at the same time I will also do an injection laryngoplasty, because the result of the non-selective reinnervation will take at least 3 months to kick on, and it will keep on improving by up to 18 months, and it has got the success rate is a stunning 95%. Very rarely NSR fails. So I will actually try to give the option of non-selective reinnervation plus injection laryngoplasty at the time of surgery. So we will inject hyaluronic acid, so that will take care of the voice for 6 months. By the time the non-selective reinnervation effect will come, and she should be actually much better. So madam, there are 2 surgeries. And I think you are still young and healthy, so I will actually give the option of connecting a different nerve to that vocal cord, which will not only make your speaking voice normal, but you should also be able to sing.
And before that, you want to inject her?
At the time,
At the
same. It's a surgery, because GA. Anyway, you are going to take a GA. So that is a combined procedure. At that time, before starting open up the neck, you actually put the injection there, like what we did today. Then open up. Now, not for you, madam, but for the baby. In her case, the non-selective reinnervation will have some challenge, because it was a papillary carcinoma. It is an operated neck, and there is a possibility that the nerve has been cut flush with the entry point of the larynx. So you may not actually see the distal end of the nerve. So here you should be ready for intralaryngeal dissection of the recurrent laryngeal nerve. You have to open up the cricothyroid joint, identify the intralaryngeal part of the distal end of the nerve, take ansa cervicalis and connect. Okay. But that doesn't take much difference for a person who is doing it on a regular basis.
Yeah, how long after surgery or completion of radioactive iodine we should?
Radioactive iodine has no say on the thing like that. We can
And
actually-
follow up, I mean, how long we should wait for follow up to complete before taking up a surgery of
Being a papillary carcinoma thyroid, you can actually take away straight. It's not a squamous cell carcinoma. You can take straight away. And be on the follow-up for a thyroid, like with thyroglobulin and antibody. So any clarification for that case? Of course, if the facility is not there, if you cannot do that, and then again you can do a static procedure, but again this patient will not improve with thyroplasty alone because there is a gap at the vocal process. So when there is a gap at the vocal process, if you are going for a static procedure, it has to be thyroplasty plus arytenorotation. So there are two options for that patient. You can either do a static procedure, that is thyroplasty plus arytenorotation, or you can do an injection laryngoplasty with a non-selective reinnervation. Both has got very high result, but nowadays I will always prefer NSR, non-selective reinnervation or static procedure. For me, for our center, thyroplasty and arytenorotation are actually reserve procedures when very rarely NSR fails or NSR is contraindicated. There are few conditions where non-selective reinnervation is contraindicated. One is above the age of 70. I am sure that will go away because now I have done on a 72-year-old man. He has got very good result. Uncontrolled diabetes is another contraindication. None of them she has got. So she should be actually okay for a therapy.
पेपर कहाँ है इनका?
Okay, madam.
Sir, she
Excuse me,
is
sir, before taking the next patient, we also welcome our chairpersons, Dr. Shrikant Phatak and Dr. Samir Nivsarkar for this session along with Dr. Sadat and Dr. Amit.
अच्छा,
Thank you.
Hi, good morning, Srikanth.
Good morning, sir. I'm Dr. Samir.
Good morning, Samir.
This patient had a possible vocal cord involvement pre-operatively.
Yeah.
So, would you recommend doing a NSR at the time of surgery?
Yeah,
or
that is a current advice. During the table, that is why I tell that I keep on telling that every head and neck surgeon should be familiar with non-selective reinnervation. It is on the table. If the nerve is gone, you do it straight away.
Second question is, in case, is a 6-month mandatory waiting period still on, or can you do it earlier?
Is there a what?
Suppose the patient has developed a vocal cord palsy because of any other reason, it's idiopathic palsy. Do you still recommend waiting for 6 months, or? do
You have to wait because in idiopathic palsy you cannot just cut because you are going to cut the nerve, unless
Okay.
you are very sure that this nerve is not going to recover, you are not justified in doing that. So in a thyroidectomy, when the surgeon knows that the nerve has been cut, you can do straight away. But in an idiopathic palsy, there is a chance that it might recover in 6 months. Now the time has actually increased up to 8 months because I myself have seen that people who develop vocal cord palsy after cardiothoracic surgery, sometimes they recover even after 8 months. So minimum 6 to 8 months is a must.
Well, many a times during thyroidectomy, the surgeon is very sure that he has preserved the nerve, but immediate post-op there is a weakness, and usually in a month or month and a half, that nerve starts functioning again.
Yeah.
So how much time would you
That's I will
recommend?
give 6 to 8 months time.
6 to 8 months.
Before that, I will actually do an injection laryngoplasty to take it to bridge that gap. That 6 months time that injection laryngoplasty will cover. So the voice will be better. If the patient is too much bothered about the voice, I will do an injection laryngoplasty. That is a reversible procedure. So you can do that and wait.
I think Samir, the next patient is
Thank you.
waiting. We can take her. She is a MBBS doctor
Hi, madam.
and she is having spasmodic dysphonia, typically short, not able to speak properly.
Yeah. Okay, madam. How old are you?
71.
71. And what is your specialty?
Gynecologist.
You are a gynecologist. Okay. And how long you have been having this problem?
19 से
19 years.
19 से मतलब
No, I didn't get you.
2019
2019. So it is now 6 years. Before that, you didn't have any problem at all. Okay, and now you,
असल में मेरे हस्बैंड को कैंसर हो गया था
oh, okay,
बस तब से थोड़ी
right. And is the problem getting worse now, or it is static? Same.
आवाज पहले से और खराब हो गई है कि पहले जैसी है?
नहीं कभी ठीक हो लेती हूँ अच्छे से कभी नहीं बोल पाती,
What did she tell?
कभी अच्छे से बोलती नहीं।
sometimes she speaks well,
Yeah,
sometimes becomes
She-
very bad.
very bad, right. Any other illness you, because I am not very good in Hindi, any other illness you have got like high blood pressure, diabetes, nothing, you are otherwise healthy, right. And any problem with eating and drinking? No. Any problem with breathing?
No.
Have you got tremors of your hand or something like that? Nothing. Did you ever consult a neurologist to see that what is happening?
हाँ,
And what did they tell? They told it is normal. Okay. Can you just count 1 to 10? 1,
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
can you tell a count in Hindi? Ek,
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
okay. Now, if you can see her very properly, she also has got some involuntary movement of the lower jaw, right? Can you see that? Madam, can you count again? 1, 2, 3, 1.
1, 2, 3,
Can you see
Four,
some involuntary
five.
movement here?
6, 7, 8, 9,
Yes, sir, we can see.
10.
Yeah. So the dystonia group actually can come into like spasm.
Hello. Sir, please, mic is obstructing the view of the camera.
Okay,
Yes.
take from this side.
You put it the other way, yes.
Okay. Again, madam. 1,
1,
2,
2,
3.
3, 4,
You can see some
5,
spastic
6,
involuntary movement. Can you see that?
7,
Yes, sir.
Yeah. So
9,
many dystonias actually come together. So when the spasmodic dysphonia is combined with hemifacial spasm or oromandibular spasm or blepharospasm, that is known as the Meigs syndrome. That can actually happen. That's why I asked whether they have gone for a neurology. So it is a combination of a spastic disorder. Now, this is also known. Spasmodic dysphonia has got certain characters. One character is that you will be better off in a foreign language, but in the worst is will be in your language. So when she count in Ekdo, she had more problem. When she count in English, it was actually better. I don't know whether you noted that. Did you note that? Count, madam. 1 to 10.
Yes,
1,
yes.
1, 2,
louder. 1,
2, 1, 2, 3, 4, 5, 6, 7,
Now it is
8,
tight for English also, but earlier it was. Okay, count 1, 2.
1, 2, 3, 4, 5, 6, 7, 8, 9.
And the second thing is that falsetto always, generally it improves the thing. Madam, can you count in like baby voice? Like 1, 2, 3, 4. Please do that.
1, 2,
See, the
3,
spasm is gone.
4, 5, 6, 7, 8, 9, 10.
Can you appreciate the difference?
Yes, yes.
Yes,
very-
yes, sir.
1, 2,
Now normal way, 1.
1,
Normal way, 1 to 10.
1, 2, 3, 4.
See that the spasm is coming back.
6, 7,
See that?
Yeah.
And now
Yes.
tell the 7 in baby voice. 7.
7.
See that there is no spasm. That's typical of a spasmodic dysphonia. The falsetto will, and there is one more thing, auditory feedback may improve. Can you block your ear? Yeah, block your ear. Now count 1 to 10.
1, 2, 3.
See again,
4,
auditory
5,
feedback also
6,
will improve the
7,
condition.
8,
Yes.
So these are the 3 things you should look into. All are signs of spasmodic dysphonia. The falsetto will reduce the spasm. In a foreign language, it will be better. Auditory feedback will improve, and some people singing, chanting, praying, laughing, crying, chewing, they all will actually reduce the spasm. That is all well known for spasmodic dysphonia. Madam, one more test. Take deep breath and then say E for as long as you can. So it is like, I will show it. E, like that you should go as much as you can. How many seconds you can go? Take deep breath. Start. E.
E, 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 E.
Are you
एक
taking in
सांस
breath in
में-
between? Don't take breath in between.
एक सांस में जितना लंबा
Single
बोल
breath.
सकते हैं बोलिए.
Single breath. Take breath and then say. Yeah, generally a spasmodic dysphonia MPD will be very prolonged, but in a very severe spasmodic dysphonia it will be delayed. But it's actually quite a severe dysphonia, so its MPD is less. Now we will do the scoping.
Yeah.
Okay, please give me. But I will spray your nose. But you can see that she has got this mandibular, oral mandibular spasm is there. Dystonia is there. And this is xylocaine, okay? Xylocaine. This is lignocaine. It will be stinging for a minute, 10%. That's the difficult part. Otherwise, you will be okay. That's all. Difficult part is over. It will be okay in a minute. Madam, have you noted that when you pray, when you chant, when you sigh, when you yawn, or when you cough, does the voice become better? Have you noted any condition which will make your voice better? Any condition? Which one? Yeah, when you are tension free, you are better. And when you are seeing a new person and a stranger, the condition become bad. Is that right? When there is a tension, it is bad. Yeah, that's also typical of a spasmodic dysphonia. But here the problem is it is not just spasmodic dysphonia alone. She has got other dystonias also. Her, you can see that oral the orbicularis oris dystonia. You can see it very clearly now. That orbicularis oris keep on jelly, please. Okay. What did he tell? Yeah, okay, I understand. Okay.
Jaskaran, give mic to patient.
What did she ask?
मैम आप क्या कह रहे हैं थोड़ा बताइए इसमें माइक में बोलिए
मेरा हस्बैंड को कैंसर हुआ
हस्बैंड
Yeah, I understand
और
that.
वो यूएस में था ओनली सन
सर हस्बैंड
Actually, her son is in USA.
Yeah,
He left there,
yeah,
and she came alone today.
yeah, okay, fine. This is only a scopy, nothing.
ये तो स्कूपी मैडम, मैंने बात करी थी आपके
Actually-
बेटे से, आप डरिए नहीं, कुछ भी नहीं होगा
It's
आपको,
only a 1 minute thing.
है ना? I am here, don't worry.
This is only a
Don't
1
worry. I
minute
talked
thing.
to
It's not a pain.
Jain Saab also.
Breathe gently through your mouth. Through your mouth. Keep the mouth open little.
मुंह से सांस लीजिए प्लीज.
Ask her to say, I.
ई बोलिए, ई. Very good.
There is some spasm of the palate also in the beginning. Okay, okay, okay. Now breathe
Okay.
through your nose.
अब नाक से सांस लीजिए मैडम. Very good.
Now the thing is that you have to differentiate between a tremor, laryngeal tremor and ASD. Sometimes both of them coexist. In laryngeal tremor, the whole larynx will shake.
Yes.
So we will see, say, ask him to say,
ई. Whole larynx and surrounding.
That is more of an adductor spasm only. There is some overlap, but the predominant thing is actually spasm. Now, can you produce that baby voice, madam? Continuous.
बच्चे की आवाज
No, no, no.
निकालिए. Continuous.
Continuous. Now, okay. Count in baby voice. 1. See that? It's better. 6.
बच्चे की आवाज में.
8, 9. Now in normal voice.
अब नॉर्मल आवाज में बोलिए.
Are give mic to the patient.
3, 4, 5, 6, 7, 8, 9, 10.
So, okay, again in Hindi, ek.
1, 2,
Then you see that do was a
4,
spasm.
5,
Now,
6, 7, 8,
okay,
9,
okay,
10.
madam. Switch on the strobe. Switch on the strobe. Okay, now count. 1,
1,
ah,
2,
ah,
3,
ah,
4,
ah,
5,
ah,
6,
ah,
7,
ah,
8,
ah.
9,
See that
10.
it's a typical adductor spasm. Continuous E, E,
E,
E, E, E. See, that's our spasm only. It is more severe adductor. And baby voice. Now block your ear with one finger. Any ear is fine. And now say normally. Okay, that is a spasmodic dysphonia only. Tremor is very little, but she has got a features of. You can see that Meiggs syndrome part is there. You can see that even when she is sitting, simply sitting, you see that some orbicularis oris spasm.
Yeah.
So that's known as a Meiggs syndrome. M-E-I-G-E. Meiggs syndrome. That's one part of laryngeal dystonia. So the question here comes, madam, it is not a serious disease, but it is a big nuisance disease. And as you told, a stress plays a role. Tension sometimes actually make the condition worse. So there are 3 ways of going at it. 1, you don't take any treatment. It is not a killer disease, nothing. But it's a nuisance. If you don't mind about your speech, fine, nothing. But if you want to improve the voice, there are 2 ways of going at it.
You, US,
What did he say?
US के है
क्या यूएस में ले जाना चाहते हैं?
हाँ तो वो इंटरव्यू है उसका
हाँ हाँ.
तो वो कह रहे हैं इंजेक्शन लगवाना
इंजेक्शन लगवाना चाहते हैं. Yeah, I think must have explained his son for Botox.
Yeah, I'm coming to that, madam. Let me come like. There are 3 methods, 3 way of going at it. One is you don't take any treatment, nothing. It is not a serious disorder, but it's a nuisance. But if you want to improve the voice, there are 2 ways of it.
Achha.
One is injecting Botox into your vocal cords, right? So Botox you actually inject into the both vocal cords. The good thing about Botox is that it is not an operation. You need not be in the hospital. You can come get as an outpatient injection, go back. The bad thing about Botox is that the maximum effect it lasts is only 6 months. Every 6 months you have to inject. There is one more problem with the Botox is that when you inject Botox, first 2-3 weeks your voice will be very, very breathy. It will be like that. Then only the voice will become okay, right? These are the main thing. And as the injection become more and more, it may become a little bit difficult, but still you can manage. That is the first line of treatment. So the advantage is that no surgery, nothing, no hospitalization. You can just get injection, but every 4 to 6 months you may have to have an injection. That is one thing. It is under local anesthesia, no need of any anesthesia or anything. Second is that you actually do a surgery correction. So in spasmodic dysphonia, what is happening is that the muscle which actually cause the vocal cord to meet together, they are uncontrolled. So they keep on, instead of just like they are so in between, their voice becomes like this, right? So that muscle is overacting. Botox, whenever you inject into any muscle, that muscle will become flat. Then, but no effect, whether it is a good effect of Botox or bad effect of the Botox is permanent. Nothing is permanent, it will go away after some day. So that's one problem. So Botox will weaken the muscle. With surgery also you can actually weaken the muscle. You can actually take part of the muscle out, that the muscle which will actually contract. There are different ways. You can actually do endoscopically or you can even do externally. So that is entirely your choice. Whether you need a treatment, if you need a treatment, whether you need surgery or Botox, if you are doing a surgery, you want it endoscopically or externally. It's entirely up to you. You can take your own time and decide and then.
ले लो मैडम को.
Sir, how to differentiate between adductor and abductor spasm?
This is an adductor spasm. In abductor,
Lulu?
there will be the voice will be actually instead of the
IT में बैठा लो.
strain voice. So I will classically say adductor spasmodic dysphonia. If you ask him to count, he will tell 1, 2, 3, 4 like that. In abductor spasmodic dysphonia, especially classically, it will be words with fricative sound, means F and S will be way. So they will tell something like 1, 2, 3, 4, 5, 6, 7 like that. The adductor will 4, abductor will 4.
Treatments are both of them.
Yeah, in abductor spasmodic dysphonia, the offending muscle is posterior cricoid node. In adductor spasmodic dysphonia, the offending muscle is thyroid node. So you have to inject Botox, you have to inject Botox into the PCA in an abductor spasmodic dysphonia, TA into the adductor spasmodic dysphonia. In adductor, you can inject bilaterally. In abductor, you can inject only one side, because you know that if you knock off both posterior cricoid node at the same time, patient will have breathing difficulty.
And which is the commonest, abductor or
Adductor,
adductor?
85% of them are adductor. Abductor is a rare condition.
Which we have seen now.
This is adductor, this is the adductor.
This is the adductor. Yeah, please sit.
Jay Kumar sir, good morning.
Yes, yeah,
Shrikant here.
Yes,
How do you differentiate mixed type of spasmodic dysphonia?
Yeah, sometimes there is a theory that everybody has got a mixed dysphonia. I don't believe that, but occasionally you get a problem where both will be there. So then the plan is that which is more dominant. If the adductor component is more dominant, treat it as an adductor spasmodic dysphonia. If the abductor component is more, it is actually the abductor. And I think you know that I have described a sign for the abductor spasmodic dysphonia. That is a classical sign. Each time the abductor spasm comes, the ala nasi will flare. So that is a telltale diagnostic sign. If that is there, then you know that you are dealing with an abductor.
Sir, this patient is referred by Dr. Sadat Qureshi. He has got bilateral abductor palsy. For this, they have tracheostomize this patient.
How did he develop a vocal cord palsy? Idiopathic or some cause, something like that?
I think it was idiopathic only.
When was that?
कब डली थी ट्यूब? 5 महीने पहले, 5 months before.
5 months back, he developed breathing difficulty.
Yes.
Sudden onset.
Sudden onset.
And then he was into the hospital, and they did an emergency tracheostomy.
And the ENT surgeon has seen, and he diagnosed as a bilateral abductor palsy.
Okay.
So tracheostomy was done because he has
And
got a
no
spider.
obvious cause has been found out.
No.
They have done a scan, radiological investigation of a skull-based sternal angle.
I think they have.
Any obvious cause for that? Idiopathic bilateral cord palsy is not a rare entity, it can happen, but obviously you need to rule out anything. And when you are a bilateral cord palsy, in unilateral cord palsy you can have problem anywhere from the skull base to sternal angle, but in a bilateral cord palsy idiopathic, the area you have to maximum concentrate is actually the mediastinum, because the nerve come closer to each other. Occasionally you can get a rare condition where there is a neurofibromatosis at the skull base both sides, but that is a rare thing. So a bilateral cord palsy idiopathic, first thing you need to rule out is there is nothing wrong in the mediastinum going on, superior mediastinum, where the nerve actually curve around the arch of aorta on the left side and the subclavian on the right side.
CT brain and chest both are normal.
CT.
I think Sadat is there in the crowd also. If he has to say anything, Sadat can detail. Yes, Sadat?
Good morning, sir.
Good morning.
Qureshi. Sir, we couldn't find any obvious cause. CTs were normal. Otherwise, also the patient didn't give any history of any stroke or ischemia. He is conscious oriented. No other symptoms.
Did it
So-
happen all of a sudden or was it gradual?
Sir, I think it happened all of a sudden.
All of a sudden, oh really,
Yes,
right.
sir.
Okay, and then you had to do a tracheostomy. He didn't have any problem with eating and drinking.
No, sir.
And his voice was okay?
His voice was not really okay. It was kind of a husky.
Okay. And he is not a hypertensive, diabetic, anything else?
No, sir. No, sir.
Nothing. How old is he now?
Sir, I don't know. I don't remember right now.
Yeah, I will ask him.
54 year.
54 otherwise. What is his job?
दादा क्या करते हो? मैकेनिक का काम. He is a mechanic. Automobile mechanic. BHL. Okay.
Yeah. Can you take that out this? So you can see it's on a tracheostomy without inner tube. Okay. And when was the tracheostomy done? 5 months back.
Yeah, 5 months back.
Okay. Spray, please. Spray. Tell him that he will cough. I am going to spray his tracheostomy. He will have cough. Keep some towel or handkerchief, something like that. So tell him that he will cough when I spray tracheostomy. Give it him. Give it him. Yeah, I'm going. Tell him that he will cough.
खांसी आएगी दादा, ये इस पे रख लेना सामने, है ना, जो दिया तुमको. एक मिनट. आराम से थोड़ा लगेगा दादा, अभी सही हो जाएगा.
That's all.
ठीक है, हो गया. खांसी आ रही है क्या? नहीं ना?
It's okay. Scope. Yeah, but give me the savalon. Jelly. Yeah, it's okay. Yeah, turn around. Tell him that I'm doing the scope.
आपके नाक के अंदर स्कोप डालेंगे, कोई तकलीफ नहीं होगी. खांसी आए ना तो अपने उस पे वो आपके हाथ में जो
Don't keep the head like that.
नीचे रखो. हाँ, शाबाश. खांसी जैसा आए तो बेटा धर्मेंद्र इनके उस पर रख देना, सर को थोड़ा सपोर्ट दे दो, बस आराम से हो जाएगा दादा, चिंता नहीं करो.
Ask him to breathe through the nose.
नाक से सांस लो दादा, नाक से. बस हो गया.
Yeah.
अब बस.
Okay.
आराम से दादा.
Say
ई बोलो दादा. इस पे लगा कि ई बोलो, छेद पे. एक बार थूक गटक ले. बस रुक जाओ. हाँ, अब बोलो ई. आराम से दादा, परेशान मत हो. Lot of pooling of saliva is there.
E.
Bolo. Should we do suction from the nose?
Ask him to cough out everything. He has got lot of sugar.
दादा खांसी कर लो थोड़ी सी.
We may be dealing with. He's a smoker.
आप बीड़ी पीते थे दादा? नहीं, कभी नहीं पी साहब. ज्यादा खाते थे सर ये.
Use
tobacco, yes.
Ask him to spit out whatever it is.
अच्छा.
Cough out and then.
ये निकाल दो जरा, एक मिनट. ये एक मिनट.
Give me something to spit.
दो ना यार, पैड दो बेटा, एक पैड दो ना.
Ask him to.
थूक दो.
No.
मुंह से थूक दो. हाँ, और थूको. सब निकालो बाहर, तभी देख पाएंगे ना अंदर. सक्शन है क्या यार?
Stop is not needed.
सक्शन चला दो ना. एक मिनट.
He certainly need an examination under anesthesia. There is something pathological going on there. On the vocal cord. It's not a normal vocal cord. Yeah, turn around to me.
एक मिनट सर, ये सक्शन कर रहे थोड़ा सा.
Okay, do that.
तो दादा रुक जाओ, आराम से एक बार अच्छी तरह साफ कर लें, फिर ताकि देख पाओ अच्छी तरीके से. दादा आप बोलो, आराम से करवा लो साफ, अच्छी तरह करो यार. हैं? मुंह में नहीं है? चलो गटक लो जो भी है. चलो पलटो उधर साहब की तरफ.
Yeah. No. Keep the. Don't.
थोड़ा मुंडी झुका के रखो दादा.
Say E. E bolo. E. That looks very unhealthy.
Very unhealthy.
Very unhealthy. Can you put the NBA? NBA on? Which one?
Sir, we have one more scope in which suction is there.
Do we have, does he have laryngeal
That is
inflammation also?
Yeah.
We have scope with suction.
Yeah.
We have a scope with suction, sir. Can you
This
use?
is all suspicious lesion. See that?
Yeah.
On the right side. This is a most probably a supraglottic malignancy, right? Yeah, right. You can see that. See that intracapillary, papillary loops are there. See that different kind of blood vessels, prominent head dent. See that question mark like of hairpin bends. Can you see all those things? They all are suspicious signs.
Yeah.
Yeah. See that question mark type of.
Question mark type,
Type.
yes.
Yeah.
Very typical
See
of
that?
NBI.
See that? In the center of the
Yes,
scope?
yes.
See the.
Yes, in the center,
They,
yes.
they all are unusual. So this is almost sure it is a malignancy. We need an examination under anesthesia and then do a thorough examination. You say E? E bole?
E bolo dada E.
E. Very little movement on the left side. There is something on the right side, but that glottic space is very badly. You can't see really the vocal cord properly. There is a lot of lesion here. See, this is definitely a growth. This is typical NBA sign of a malignancy. See that different direction blood vessel and with it perpendicular to the long axis of the vocal cord, the hairpin bends, the question mark thing, all these things, and like the pin heads, you see a lot of small thing. If you go very close, you can see even much better.
Yeah.
Right, and the glottic space is completely gone. There is a growth. I will just do a quick tracheoscopy, whether to see everything is okay downstairs. Several.
रेस्पिरेटरी रेस्टेज abductor palsy सीटी नेक और चेस्ट नॉर्मल है यही बोला इट इज अनबिलीवेबल क्योंकि इसके लीजन दिखा नहीं या फिर
With tracheus.
Yeah, with tracheostome.
This is most probably a suction induced or tracheostomy induced granulation. You can see the tip granuloma there.
Yeah. And we can see downstate carina is there.
And that's a carina there. This is the left carina. And that is the right carina. That looks okay, but there's a tip. The tracheostomy is already creating troubles. Can you see that here?
Sir.
Yes.
That's a granuloma. That's a tip granuloma there.
Right, sir.
So we need a definite examination under anesthesia. So for two purposes, to assess the extent of the lesion and take a biopsy.
So now the next, the case which you shown
sir.
us, left vocal cord, weakness of the right vocal cord, sir. That gentleman with fracture.
Yeah, what does he want?
He want Restylane injection.
Okay, right. That we will do. When will you do?
Right now?
Now. The other patients are finished.
They are there. But in between we can show them one procedure.
Or we can do, whichever way. I don't have a okay. Right, now, so right, bring him. He can bring.
So you were saying that on right side you are going to give injections. Okay. So we are planning the patient which sir had shown you of right vocal cord paralysis, that Lupin fellow.
Yeah,
Sir
the
will-
Boeing one.
Yes. Sir will put a Restylane injection on the right side. Right?
Which injection?
Restylane, hyaluronic acid.
Hello.
The injection is this.
Correct. Okay.
Yeah, there are there are different methods of injection. You can do endoscopically, you can do transorally, you can do transcervically. Transcervically is the commonest thing because that is an outpatient procedure because patient need not get admitted and they can actually go back. In the transcervical, there are three approaches. Transthyroid is the most common approach I use. Second common is the transthyroid fail. I will actually go for the transcricothyroid, and there is a transthyroid approach also. In transthyroid approach, the only contraindication or a relative contraindication is an old patient where the thyroid has become totally calcified. Then it may become very difficult to do that. Otherwise, you can actually generally inject, but most of the time you can actually inject. Use only thing is you need a bigger needle. Transcricothyroid is the standard technique where we inject the Botox. So sometimes if the transthyroid doesn't work, we go for the transcricothyroid also. Transthyroid is a better approach, but technically more difficult because it has to go through the very sensitive supraglottis. Supraglottis is very, very sensitive, and also you have to go through the petiole of the epiglottis. So if some bleeding happens, many patients keep on coughing. So that is my third choice only. I generally go for the thyroid, transthyroid. If thyroid doesn't work, I go for the cricothyroid. But generally, you should also tell that very, very, very rarely, exceedingly rarely, a very difficult patient, occasionally you may have to do the tender GA. That's very rare usually. Now, yeah. Say in a younger patient, you can actually use even smaller needle like 24 gauge needle, but in an older patient where there is a chance that there is partial calcification of the thyroid cartilage, it is better you go for 20 or 22. Right. So what you do is, the best anesthesia I will say that is actually, that I am not going to do now here, is xylocaine nebulization. Take 4 ml of 4% xylocaine, mix it with 6 ml of saline, so that makes it 10 ml, and nebulize it 15 minutes before the injection. It gives excellent anesthesia to the supraglottis. That actually gives very, very good anesthesia. So that is my preferred choice. But here I will actually do the pyriform fossa block with a 10% xylocaine, and more importantly, the perichondrium of the right the thyroid cartilage is very, very sensitive to pain. So it is very important that you block the perichondrium with xylocaine so that he doesn't have pain when we inject. So first is that I am going to mark the thyroid cartilage here. That's okay. You cough. What is it? 2%. Yeah. You got a pain in the left ear after the incident. Is it in the night? Is it creating trouble for your sleep? Not that severe.
But it is a little bit painful, not comfortable, I can say.
Do you have a tooth issue there? Tooth problem? No. Let me see. Open. Is it painful? Open the mouth. Open the mouth. No. Close. Is it painful?
Somebody is coming in front of camera.
That may be the joint. Let me see. Don't go. Sit comfortably backward. Yeah, right. No, I'm not. Don't keep the mouth open. I'm just doing something very. So this is the thyroid notch here. Superior thyroid notch, and this is the inferior thyroid notch. And here his main problem is on the right side. So it is somewhere here along the lower. It's like a thyroplasty window. This much region anywhere is fine. Roughly 3 millimeter from the lower border of the thyroid cartilage. So anywhere here, if you can inject, it will actually go into the paraglottic space. So this is the marking site. So what you do is you mark the superior notch of the thyroid, inferior notch of the thyroid, draw a partial line of the thyroid cord lower border and just above it a 10 into 5 millimeter window you mark like a thyroplasty. One thing you remember is that when you inject, almost every patient will actually go like that. So many times your marking may be wrong. It actually you will actually go into the subglottis, because in the neutral position when you mark it will be different. So you always think about that.
And so other locations of injection, what are the like thyroid and this is that?
Thyroid is actually into the thyroid space. Cricothyroid is here between the thyroid. But here you go straight, right? That is the way you actually inject. Now give me that 2% silocaine.
Still.
Yeah, if there was a, I don't think you have got a, have you got a chair with a head support? No.
मैं आपका head पीछे support कर देता हूँ.
Okay, right.
I'll support his head, sir.
Yeah, give me the 2% silocaine. This is not the original injection. I am just blocking that area. Okay.
थोड़ा सा आपको हल्का सा तकलीफ होगी.
So I am just going to mark the say the thyroid window. I am going to inject the perichondrium because that is very sensitive to pain. This is the perichondrium. I am going to inject there so that he doesn't have pain. Otherwise it may be painful.
So it is a 5 millimeter above the anterior border.
3 millimeter. Okay. Now I give 10% silocaine. Yeah. This is a different. I am going to spray into your mouth. Okay. Stick out the tongue. Out. So go along the lateral border as much. Go direct into the pyriform fossa. Do it. Okay. That will block the superior laryngeal. Now repeat the same thing. Out. Tongue out. That's all. Now we will wait for. Yeah. Swallow. Yeah, 20 or 22 is fine. 20. Injection. Usually, there will be about a week time. You are a singer. All singers are having problem today, right? Okay. Okay. Now, who is going to do the scopy for me? You can stay like that. You do it on the other side, son. If you can go a little bit to that side. No, I think, because can you just get up, sir, a little bit? Yeah, sit now. Okay. Yeah. Keep your head supported. Yeah. Okay, just cough out little bit of phlegm is there. Do this. Ah, right, okay, swallow. Okay, that is enough. Just stay like that. Go a little more nearer. Yeah, that is the position I want. Okay. That is little bit high up. Can you see that now? Can you see that? Sorry. Sorry. Relax, 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 relax. Okay, leave it, leave it. Spit out the blood. Don't worry, don't worry, don't worry. We'll wait. Spit out the blood. He give his kidney tray to him. He has got some blood there. Oh, he's on ecosprin. Yeah, that is also reason. Okay. Spit out whatever blood is there. I think give a kidney tray. I don't think he can actually spit on that. Yeah, I saw the needle, correct. Yeah, but it was little bit high up. That's not the correct position. There will be some blood, don't worry. Yeah. Okay. Swallow. Swallow the saliva. Okay, now you can do. Cotton ball, give me a cotton ball. Yeah, yeah, go. Yeah. Swallow again. I think it is okay now. Yeah. Yeah, okay, relax now. Now relax, relax. Don't do anything. A little more, little more. Little more. Yeah, that's okay. Can you see that? Yes, sir. Yes. See that?
Yes, sir. Yes, sir. Yo. Now we see the swelling.
Can you see that it is actually bulged out?
Yes, sir.
Can you see that earlier it was concave? Can you see that now? Yes, sir. Out.
Yes.
Say E now. See that sound already came. Can you see that? E. Count.
Give mic to patient.
Yeah. Count. E. See that he didn't have any sound. Count 1. 2. Now this is because of the irritation of the blood. The muscle will be under spasm. But in 2-3 days time it will become very good. Now we can see that it is straightened. Can you see that now?
Yes, sir.
The
yes,
right
sir.
vocal cord is straightened.
It's gone.
Yeah. Okay, that's all. You cough, you will have already voice now, but the good voice will come, it will take around 7 to 10 days time. Today there will be some, but still you will have voice now. Just spit out and come and then we will speak again. Can you spit and come? Go to the wash basin. There will be some blood inside your throat. Just wash it thoroughly and then come back. Yeah. Anywhere, it should be anterior to the vocal process. That's all. Anywhere, because paraglottic space is a continuous entity. Wherever you enter, it will actually even out. 1 cc. It's a preloaded thing. Juvedem as well as Restylane come as 1 cc thing. If somebody is on a clopidogrel, I will not actually advise this technique because it can create trouble. He's on aspirin, that's okay. So if he's on clopidogrel and if he cannot withdraw it for 5 days, it is better you do under anesthesia control endoscopically, like what did he in the morning. But otherwise, this is a simple procedure, but it's not a simple procedure. It takes some experience, but it will be finished in 1 minute. Once you are familiar with the technique, now I have been a proponent of this technique. I actually tell everywhere, this is not actually a laryngologist surgery, it is actually a general ENT surgery, because a unilateral vocal cord palsy, first management has to be done by the general ENT surgeon. And I think every ENT PG should be taught how to do a proper injection laryngoplasty.
Hello.
Yeah.
Sir, just want to know, do you do it always in a sitting position?
Yeah, sitting position. But for a beginner, you can actually do also under the lying position. But the best thing is actually a dental chair.
Okay.
So that patient will actually head his rest against the thing and the head will be very well extended. So that will be the best position. But the key is the anesthesia. And this today, because of the shortage of time, I just sprayed both pyriform fossa. That is good enough. But patient will be spectacularly cooperative if you do a xylocaine nebulization. Take 4 cc's for 4% xylocaine, mix it with 6 ml of saline, make it 10 ml. Give a good nebulization 10 minutes before the procedure. Patient will not have any problem at all. And another thing is that you need a competent assistant to do a steady, flexible laryngoscopy. So 2 people are needed for this procedure. Please come, sir.
Markings for male and female are different.
Same, like a thyroplasty window. In a female, it is little more anterior. In a male, it is 7 millimeter posterior. So, like a thyroplasty window, you mark it right. Okay, give the mic. Give the mic to him. Sir, just cough a little bit. And now say ah. Count 1 to 10. 1,
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
You heard that he didn't have any voice at that time, and mind you, this is beginning, because when you inject, and especially somebody on aspirin, there will be blood, and blood is a high irritant for the larynx, so they go for a spasm. Once a spasm settles, his voice will become very good. Okay, you can even cough better. See that his cough is now better, he can actually cough.
Yes, sir, we can appreciate.
Oh, okay.
Okay.
Oral medication.
Right. So wait for, no, speak the other voice. Don't say like that. Speak in your normal voice.
Normal.
Little more.
Thank you, sir.
Now you have got a habit. You forgot your voice. You try to speak in, but a few minutes it will be a little bit irritating. Don't worry about it. Once the anesthesia is gone, you will be better. Okay.
Sir, any other medication to be given orally?
Nothing.
Nothing. Okay, thanks.
If you have got pain, you take painkiller. If you have got pain because of the injection, because you are on aspirin, that is the only thing, because there will be some hematoma there. So if you have got pain, take paracetamol. Yeah, not paracetamol. Paracetamol.
Normal voice पे बात कीजिए.
Paracetamol.
Why you want to speak in the old voice? Right, okay, right, nice.
Thank you, sir.
No, thank you. Thank you.
No. Normal voice.
Thanks that you are here.
Right. Okay, right. Your voice will be better. Okay, so that's about the injection laryngoplasty. You can also do cricothyroid, thyrohyoid. There are 3 approaches. In a beginner, I will always tell that when you are in a beginner and you don't have enough expertise, always take the anticipatory bail. Tell the patient that very rarely I may not be able to inject because there is a problem, because this is an expensive injection, no? It goes somewhere around, the Restylane goes somewhere around 15,000 and Duodem goes somewhere around 20,000. So you can't tell that you can't inject. So always tell, in the first few cases, tell that if there is a problem, sometimes you can have problem. In that case, I will give you a short anesthesia and inject endoscopically. So always take that precaution so you will be safe. Okay. Any other clarification for this procedure?
It's clear, sir.
Okay, right.
Sir, there is a good news, the house is full and we are arranging for additional chairs.
Very good.
The hall.
Right, thank you. Okay, now we come to the next case. Yeah, please, where is Jaskaran? Jaskaran or SP, somebody I suppose. Yeah, we'll take the history, Jaskaran.
हाँ, थोड़ा अपना तकलीफ बताइए क्या है?
ये हमारे आवाज़ से थोड़ी सी प्रॉब्लम हो रही थी बात करने में।
So he is having difficulty in speaking, sir.
How long?
कब से?
ये एक आध डेढ़ महीना हो गया है।
1.5 months, 1.5 months.
2 महीने
1.5 months he has got voice problem, right?
2 महीने के करीब 1.5 से 2 महीने के आसपास।
Around 2 months, 1.5.
It happened all of a sudden?
एकदम से आवाज गया था कि
नहीं आवाज़ गया नहीं था, बस ऐसा ही आवाज़ है जैसा।
नॉट ऑल ऑफ ए सडन। ये प्रॉब्लम जो आपको आ रहा है
जी
एकदम से आया था कि धीरे धीरे आया था?
एकदम से ही, मतलब आवाज़ हमने सोचा कि हो सके कुछ खाने पीने से हो गया होगा, तो गरारा करे ये वो करे इस टाइप से, फिर डॉक्टर साहब को दिखाए।
So actually suddenly it was like that. He thought like something is wrong, so he did some gargling and then shown to some doctor.
हाँ, मतलब जो भी चीज़ें होती है घर में वो कर लिए थे तो।
Whatever was there at his house, so for home remedies he tried, sir.
Okay.
He thought like something food or something has caused this voice.
But no problem with eating and drinking, no problem with breathing.
राजेश दिक्कत आती है आपको?
नहीं कोई प्रॉब्लम।
नो प्रॉब्लम।
And no breathing problem issue. No,
सांस लेने में तकलीफ होती है?
कोई दिक्कत
नहीं, सांस में नो प्रॉब्लम।
Okay, we are seeing for the first time, but so I don't know whether so does the others say that your voice is not, or is it his feeling only, or the listeners also say that your voice is bad?
जो आवाज आपको तकलीफ होती है वो आपको खुद महसूस होती है कि
हाँ,
दूसरे लोग आपको बोलते हैं कि
नहीं, दूसरे लोग नहीं बोलते, मुझे खुद को ही महसूस होता है।
himself feel that his voice is
But what about others?
Others we don't feel that.
That's an important history. He say that he has got a voice problem, but the others don't feel it. So that
दूसरे लोगों को
नहीं कोई नहीं।
so that means it is a subtle thing, no, right? That's very important, because when listening to him, I didn't feel that.
Yes,
No, it was really bad. So we'll have to see, right? Any other illness?
और कोई आपको तकलीफ है, कुछ डायबिटीज, हाइपरटेंशन, बीपी की?
बीपी नहीं, शुगर है।
शुगर इज अ डायबिटिक।
He is on diabetic. How old is he?
कितनी उम्र कितनी है आपका?
अभी हमारी
38 years.
38. Smoker?
स्मोकर बहुत कम, बहुत
Very rarely.
Drinks?
कुछ नहीं, गुटखा भी नहीं,
कितना करते हो?
कुछ
दिन
भी
में
नहीं।
एक दफा?
एक आध बार कभी पी लेते थे ऐसे,
दिन में?
डेली वाला काम नहीं।
नहीं, स्मोकिंग की बात।
हाँ,
दिन में एक सिगरेट?
एक हाथ सिगरेट सुबह।
जसकरण,
जी सर।
जसकरण थोड़ा साइड में।
Does he use tobacco, pan chewing, something
No,
like?
she's not tobacco. जर्दा तंबाकू तो नहीं
कुछ
लेते?
नहीं, कुछ नहीं।
Nothing. And what is his job?
अब क्या काम क्या करते हैं?
हम सर्विस करते हैं।
कौन सी सर्विस?
ये कंस्ट्रक्शन के हैं, सुपरवाइजरी।
He's a supervisor somewhere.
In a construction company.
Construction.
Yeah, that's very important, that history, because when somebody is in a construction company, there is a lot of background noise. So they keep on shouting above the background noise. So they are more likely to develop vocal cord bleeds and all.
आपके आसपास शोर शराबे वाली मशीनें रहती हैं?
हाँ, रहती है।
Yeah, that's a very important history. Background noise. His persistent
गिट्टी
workplace
डालता
is
है
a
ना।
background noise.
मशीनें गिट्टी वगैरह डालती है तो।
मशीन कंस्ट्रक्शन।
Yeah, that's a typical history, right? Because he has he has to shout over the top. Now, just ask him to do the MPD. Take deep breath and just say E for as long as you.
और एक सांस में आपको 1 से 10 तक काउंट कीजिए।
1 2 3
No. E, full breath. Full breath and then
लंबा सांस लियो और ई बोलना है।
as much as you can.
ई।
No, he didn't get it.
जब तक बोल पाओ। लंबा सांस लीजिए।
It 12 seconds, it's not bad, so that means the vocal cords are meeting. Spray. Okay. Right. Strobe connection. Jelly. Tell him that I am going through the nose.
Yeah, please switch into the endoscopy picture.
Can you see the endoscope now?
Yes, sir.
Ask him to breathe through the mouth.
आप ना मुंह से सांस लीजिए, मुंह खोले, अपने नाक से नहीं, मुंह खोल के सांस लीजिए, शाबाश.
Yeah, now breathe through the nose.
अब नाक से सांस लीजिए, मुंह हाँ.
Yeah. Okay, okay, gentle, gentle, gentle. Ask him to swallow.
आप हल्का सा गटको, हाँ, very good. एक बारी बस गटकना.
Okay. Ask him to swallow once
एक
again.
बारी फिर से swallow कीजिए.
There is,
गटको एक बारी.
there is a small hemorrhagic polyp on the right side, very small. Can you see that?
Yes, sir.
You can
Yes,
see
sir.
that, no?
Left side.
Yes, sir, yes.
Yes, swallow
एक बारी
once
गटको,
again.
राजे गटको.
Yeah, yeah, yeah.
नहीं,
Okay,
आराम से,
okay,
आराम
okay,
से,
okay.
आराम से. बस,
Now
बस,
ask him,
बस.
straw bone, straw bone.
Sir, second number.
Press.
ये वाला?
Yeah. No, no, that is. Yeah, straw bone. Now say continuous. Mic is not settled. Still not picking it up, but don't worry. But okay, cut off the strobe and put the NBA. You can see that a benign lesion and a malignant lesion difference. This is the benign lesion. You can see now that will be a bluish color, that whole polyp. Swallow?
Yes.
गटको, राजे गटको एक बारी. गटको.
Yeah. See that? This
Yes, sir.
uniform bluish.
Blue.
Uniform blue, right? There is no, swallow again.
एक बारी गटको, फिर से, शाबाश. बस एक बारी, फिर से गटको. हाँ.
No, swallow once again.
नहीं, फिर से गटको राजे.
Yeah, yeah, yeah. Okay, okay, leave it.
अब
See that uniform blue with a little bit of
Yes.
mucus around it. Can you see that? And
Yes,
see,
sir.
see the longitudinal vessels over the vocal cord. Can you see the longitudinal vessels?
Yes,
In
sir.
the long axis of the vocal cord. Swallow.
गटको, एक बार फिर से गटको, शाबाश. गटको. हाँ, बस.
All right. Okay, okay, okay,
बस एक
okay.
बारी,
Don't,
एक
don't,
बारी,
don't,
बस
don't.
अब शांत रहो.
Don't.
बिल्कुल शांत रहो.
Okay, that's okay. See that? Lot of blood vessels, but they are all in the longitudinal axis. Can you see that? There is no clumping like of thing. There is no blood vessel going to the infraglottis. Can you see that?
Yes, sir.
Yeah. This is a inflammation only. This longitudinal prominent blood vessels suggest inflammation, and the lesion is uniformly blue, so it is totally a benign condition. It's typical of his job, because he is working in a construction company where there is plenty of background noise. That is a typical way. So he must be shouting over the top of the voice. So he is putting a lot of injury to the subglottic pressure. The blood vessels, the dilated blood vessel leak, and it has hemorrhage, and now it has become organized. But see that it is still blood red. So that means if he take proper voice rest, it will resolve by itself. If he doesn't take rest, it will become a standard polyp. Then we will have to excise it. I don't know whether he can take a rest for 2 weeks. I don't know. It is because of his job is very different. But it is nothing serious. No cancer, no malignancy, nothing like it. It's a pure hemorrhagic polyp. And also we will have to instruct him, because his job is such that it is safer for him to use a microphone always to communicate with other people. Otherwise he will shout over the top and he will again have bleed.
So how to differentiate between hemangioma and hemorrhagic polyps?
Hemangioma, hemangioma is a rare thing in the vocal cord, and on the vocal cord it is very rare. It usually happens in the supraglottis and the subglottis, right? You can get a capillary hemangioma, which is very slightly more bluish even without NBI. This is reddish, and it will be irregular like that. Cavernous capillary hemangioma is a blood red. It's usually occur in the subglottis and usually in the pediatric age group.
So for this patient, beta blocker will have some role or no? Sir,
Any clarification from the
क्या
previous
तकलीफ
patient?
कब से नहीं है? क्या
It's okay,
तकलीफ?
sir.
Okay, I can continue with the next?
So we are going for the
Yes,
next
sir.
patient.
Yeah.
क्या आपकी मुश्किल क्या आती है आपको सर?
कुछ नहीं हुआ था, आवाज बंद हो
So he had
Mike.
difficulty in voice.
He has got bad voice. बोलिए आप बता के
गई। हाँ? अमर सागर
क्या काम करते हो?
पेंटिंग का इंस्ट्रक्टर
आवाज खराब है.
हो गई करीब 1.25 महीना।
What is he? What is his job?
He is a painter.
Painter.
Since 1.5 months his voice is bad.
One and a half months.
हाँ 1.5 months.
Did it happen suddenly?
ये अचानक हुआ.
हाँ अचानक हुआ।
Sudden onset.
हाँ
Did you have at that time a cold or fever or something?
Cough and cold तो नहीं था.
नहीं कुछ नहीं।
Okay, sudden onset, 1.5. When you have a sudden onset, usually two things. Either it is a paralysis or it is a hemorrhage and a polyp has happened. Something like that. It need not be always correct, but these two things you have to keep in mind. Any problem with eating and drinking? Any problem with breathing?
सांस लेने में कोई तकलीफ?
No. Any other illness? High blood pressure, diabetes, diabetes, sugar, and BP,
थोड़ा सा
cholesterol,
है।
all are on medication. Thyroid problem,
नो
asthma,
नो
gas problem,
नो हाँ बस
gas, smoker,
नो
drinks.
कभी कभी
Okay. Yeah, MPD, maximum phonation duration.
एक लंबी सांस लेके अपने को बोलना है ई. कितना लंबा बोल सकते हो बोलो.
Full breath. Starts. Only 5 seconds. Can you? Did he take full breath?
एक बार अच्छी तरह सांस लेके बोलो.
MPD is very poor, 4-5 seconds, sudden onset, so it could be a vocal cord palsy, we will see. Spray. Tell him that it will sting for a minute. 1 minute.
करवा चुका पहले.
That's what the difficult part is. Strobe required, yeah.
We have done his copy before.
What was the finding?
It was a sulcus right vocal cord.
So then why sulcus shouldn't produce, in what age is his age?
His age is
He say that
55.
before 6 months, 6 weeks, his voice was perfect, you know.
हाँ.
That is, that doesn't fit with the sulcus system.
Okay. कैमरे के सामने मत जाया करो.
Jelly.
ये समझते नहीं हो क्या?
Put it there, I will take it. Okay. No. So tell him that I am going to do the scopy through the nose. Keep the mouth open, breathe.
मुंह खोल के रखो दादा. Did you get the endoscopy picture, boss?
Yes.
Okay.
So before you go into you just check the palate. Say ah. That is normal. Palate is normal. Okay. Breathe through the nose. Say E. See the left vocal cord palsy. Can you see that? E.
Yes, sir. Very clear.
E. Left vocal cord is atrophied. You can see that at the vocal process level it is meeting. At the arytenoid level it is meeting, but the anterior two-third it is gone. So this is a typical thyroarytenoid paralysis. Lateral cricoid node is reasonably in good shape. Posterior cricoid node is gone, and if I go very close, you will see large ventricle. That means there is some atrophy of the vocal cord. See, I am going nearby. Compare the ventricle on both sides. Can you see the difference?
Yes, sir.
The left vocal cord is actually atrophic. Can you see that? Yes. See the transverse width of the right vocal cord, which is quite bulky. See on the left side?
Yeah.
Very atrophic. See that?
Yes, sir.
So that's a left vocal cord palsy thyroarytenoid. E bolo. See that at the vocal process level it is meeting. Can you see that? E.
Yes, sir. Yes.
See. So that means lateral cricoid node has got still good tone, but thyroid node is gone. That is why it is bowing. So it's like any other unilateral vocal cord palsy. So we need to investigate, make sure that there is no obvious cause. So The first thing is actually a CT scan of the neck from skull base to sternal angle. Make sure that there is nothing wrong there. If it is negative, then we go for the standard treatment. So the 3-point dream. Give a neurotropic agent like B1, B6, B12 combination like Rener or Neurobion. Teach him the half swallow boom exercise, and if he is very particular to have improved voice, do the injection laryngoplasty. That's a standard treatment, but you need to get the CT scan. Make sure that we are not dealing with something else.
Okay, right. I will explain him, sir. आ जाइए, लिख दो भाई इन्वेस्टिगेशन लिख दो, अगले पेशेंट को बुलाओ. Next is for Botox. So the patient which we have seen of spasmodic dysphonia, they will plan Botox for her.
But she doesn't have anybody today. She told she doesn't have any
No,
relative.
she is having relatives. She was standing outside. I talked to her. I talked to his son in America also. They are agree. I explained them 3 options. Number 1, no treatment. Number 2,
Botox.
injection, Botox.
Number
3,
surgery.
surgery. So his son was agreeing that I can go for Botox right now, and one fellow is there with her. आइए,
Okay.
बैठिए मैडम. सर को Botox दिखा दो.
I think it is better in lying position.
Okay.
She can
Then-
lie. She can lie down.
इनको दिखा, लेटा दो इस पे.
You can lie down, madam. That is better.
इधर लगाओ ना वो प्लेटफॉर्म.
Lie down. Lie down.
और मैडम को लाई डाउन करके एक कपड़ा उड़ा दो.
What did she ask? Yeah, this is the which one you use in the morning, no?
Yes.
The same thing. Yesterday we used.
Yeah, sure. बेटा एक कवर कर देना.
So now Botox injection to the madam, you can lie down, to the thyroarytenoid muscle. 2.5 units into each vocal cord is a standard dose for a beginner. Now there are many methods of injecting Botox. The standard, most popular or most scientifically correct is actually EMG guided, laryngeal EMG. Here it is not there. So I am just going to do the you can tell that it's an endoscopic control, but it is more of a slightly blind technique. There is a standard technique how to hit the under surface of the vocal cord. What you do is you go through the cricothyroid space. So this is not the, you can also inject like transthyroid like I injected the injection material, but Botox being a very small amount, we inject through the cricothyroid. The standard approach is that you just enter the cricothyroid through the cricothyroid space in the midline. Once you enter the midline, tilt the needle upward and laterally, so you will hit the under surface of the vocal cord and inject. I will mark it and show there. I need a small, very small extension like a sheet, little bit of sheet, just a sheet. So the good thing is that if you are doing under EMG, you can be absolutely sure that the needle is in the correct neck. Without EMG, that is little bit difficult, but still accuracy is fairly good. So you need a special needle known as the hollow needle electrode. Many companies make it. Even Botox company make it. Inojet. There are different companies, but unfortunately, all of them are American made. So we'll have to pay a lot of amount for each. Yeah, this should be okay. Madam, can you get up a little bit? Yeah, lie down flat. Okay, right. Now give me a pen. Pen. Marking pen. Hope you can see. Can you see this, her neck?
Yes, yes, sir.
So what I'm going to do is that I'm going to do the cricothyroid space here. Okay. So this is the thyroid. It's a cricod, you palpate the cricothyroid space. So mark the cricothyroid space here.
2391.
So this is the cricothyroid space, okay?
932391.
And this is the midline. Okay. So what you do is you go inside and then immediately turn the needle upward and laterally by 30 degree. So the direction of the needle will be like this. So this is 30 degree. This is how you, so you will exactly go underneath the vocal cord in this direction. So this is the standard technique. But you are entering the lumen. So patient will cough. So before that, to make her not coughing, I will inject 4% xylocaine. That's a transtracheal block. Give 2 cc of with a small needle. Not insulin, but no. The bigger, usual 27. The small, long, slender needle. No, is a slender needle. Open it. 26 or 27.
1.5 inch.
Yeah.
1.5 inch chubby needle.
Yeah, I think this. Yeah, right. Yeah, correct. Give me 2 cc, 2%, 4% xylocaine. Let's give me a syringe. Give me a syringe. You got 4% xylocaine? Can I have a swab? Yeah, just beat it. Madam, it is a very small injection, right? This is xylocaine, okay? You will cough, when I inject, you will have a cough for some 1 minute, then it will go okay. Okay? Don't worry. Eh? So what I am going to do is I am going to inject the cricothyroid space so that when I inject Botox, she won't have a problem. Now she will cough. So go in the cricothyroid space exactly in the midline. Go penetrate and there. Aspirate, see that air is coming. Now she will cough when I inject. That's all, madam. Don't worry. 1 minute you will be okay. Don't worry. In 1 minute it will go. Don't worry. Okay. So I have blocked the infraglottis. For a minute she will cough. It is very important when you do that. After that, now it is okay. But when you inject, it is always make it a point that you press that injection site for a minute, because occasionally you can actually go through the anterior jugular vein. And if anterior jugular vein is broken, there will be hematoma. Then the Botox injection become very difficult. So always after cricothyroid block, you press it here for a minute, and so that the anesthesia act and there is no hematoma. You are okay, madam? Yeah. Nothing. This is a very simple procedure, madam. No operation, nothing. Now I will just inject in a minute time. Now, where is Botox? Yeah. Syringe? Insulin syringe is there? No, I need a bigger.
So what is the dose of Botox that you are injecting now?
2.5 unit into each vocal cord.
Okay, sir.
So I take an insulin syringe. So you need calculation. This is a 50 unit vial. Okay. We have injected. We have reconstituted with 4 cc of saline. Right. So 4 cc of saline contains 50 units. That means 1 cc contains 12.5 units. Is that right? Okay.
Okay, sir.
4 cc contains 50 units. So that means 1 cc contains 12.5 unit. Okay. So 0.1 division contains 1.25 unit. And patient require 2.5 unit. That means 0.2 division on each side. So total I am going to inject just 0.4 division. Yeah. On either side. So I'm going to inject, so remember I have marked it. So you penetrate, once you enter the larynx, you get the giveaway feeling, you tilt the needle upward and laterally by 30 degree and keep on advancing. You will hit the thyroid cartilage. That is the under surface of the vocal cord, inject there. That is all. It will be great if you have got EMG because that will also doubly confirm it. Madam, don't worry. This is a very simple procedure. This is only an injection, nothing, no operation, nothing. You won't have any problem after that. Okay. So I'm just going like that here. So exactly in the midpoint. Once I ended, now tilt the needle upward and laterally by 30 degree. Keep on doing. It will go and hit the, see it hit the thyroid cartilage. It won't go further. So that is into the paraglottic space. Now inject 0.2 cc. Right side is over. Take out. No need of taking out of the skin. Again puncture. Okay, and 30 degree upward and laterally. See that in the direction of the line I have drawn. Keep on advancing.
Our hand is coming in between, sir. We cannot see
Can
properly.
you see it now?
Yeah, we can see it now.
Yeah, keep on advancing. It will hit the thyroid cartilage. So it won't go further. This is the under surface of the vocal cord. Aspirate. Make sure you're not in a vessel. Inject another 0.2 division. Finish. That's all. So what you do is, I will tell again. Mark the cricothyroid space. Mark the midpoint. You block the subglottis with a 2% silocaine 1 cc. Then mark these two lines upward and laterally 30 degree from this thing. That is the direction of the under surface of the vocal cord on both sides. And then you take Botox, puncture. The moment you get that giveaway feeling, that means you are inside the larynx. Tilt the needle upward and laterally by 30 degree in that line. Keep on advancing. It will hit against the inner perichondrium of the thyroid cartilage. And that will be the under surface of the vocal cord. Inject there, do it on the other side.
Sir, if you do not have a proper EMG setup,
Yeah.
can you use the nerve stimulator which the anesthesiologist use for
No.
nerve blocks?
No,
Because
no.
that has a needle and
No,
a
this is
electrical.
not on a nerve, this is on a muscle. You can't do that.
I think, Jayakumar sir, we have one more case of Botox also.
Yeah.
At that time, what I will do, I will put the scope from the nose and see where your needle is going on. The
But
one
it is coming
camera,
from the subglottis. You can just see it is between the vocal cord. You can't see the tip because it is going underneath the vocal cord. You can see the needle entering the subglottis.
Yeah.
After that, once I tilt 30 degree, you can't see it. It will go under surface of the vocal cord.
but at least
Yeah, you can see that.
they will have
That
some
much you
idea.
can see that. And mind you, there is one more technique. The same technique I injected for that hyaluronic acid. You can also use this technique. Transthyroid also you can inject. You can see the tending of the needle and then inject.
Then inject,
Why
right.
I didn't inject in her case is she is little older. The chance of the cartilage is becoming very calcified is very high. That also you can use it.
Right. Yes, sir.
Okay, madam, finish. That is all. Now, Botox doesn't have any immediate effect. Usually, it will take 3 days for the thing to start acting, and the peak action comes somewhere in 14 to 18 days. So, when you inject Botox into the vocal cord, you should forewarn the patient that each patient is different. But don't get upset after 3 days if she loses her voice. Don't worry, that is perfectly normal because the vocal cords have been paralyzed. So she will actually speak like that. Nothing to worry. And she also may have subclinical aspiration with liquid because the vocal cords are not adducting. So these two things you should always forewarn the patient. 3 days later you may have your voice very breathy. Don't worry at all. When you take liquid you may cough. Don't worry, that will all settle in 2-3 days time. Breathiness, usually it may be for 2 weeks, but first injection is always guesswork. So for some people, most people 2.5 unit is okay. Some people 2.5 may be more, some people 2.5 may be less. We don't know that. We will know only next day. If the injection is more, 2.5 is too much for her, what will happen is that she will have a breathy voice for 4 weeks. But then the good side is that she will have prolonged symptom-free period. Instead of 4 months, 5 months, she may have 7 months, 8 months symptom-free period. For some people, this dose may be too low. Then she will have the hold period only for 5 days, 7 days. Then correspondingly, she will have a shorter duration of thing. So first injection is always a guesswork. But was 70% of the people require only 2.5 units. So next injection onwards, by listening what was her voice for 2 weeks, then we
decide
can
the
plan
dose.
the next dose.
Right, sir. Please. Sir, next patient is a very old patient. She is non-hypertensive, non-diabetic.
She's also
but-
spasmodic dysphonia.
No, she is not spasmodic dysphonia. She is a old lady.
Madam,
She-
you know, 1 minute, you
Ah.
told madam everything. Madam, did you hear what all I think? What did I tell? Did you hear? You didn't hear anything. Few things. Few days later, your voice may become very weak. Don't worry. That is normal. It will come back, right? And sometimes, when you take liquid, you may cough little bit. This can happen after 3 days. Don't worry. That's normal. 2 weeks time, 3 weeks time, it will be okay. Right?
Sir, that old lady has got only one problem, that she loses clarity of voice.
She has got what?
Loses clarity of voice. Voice is little slurring, but there is no event of any stroke.
Can she sit or she wants to lie down?
She can sit.
Yeah.
You can examine her larynx only. That is what. Because so many old patients are coming to us, sometimes they don't have any neurological history, but they have only one complaint, that there is a weakness of voice.
How
Maybe because-
old is she?
Amma 83 ki hai, sir. She is 83.
Is she a diabetic?
No, non-diabetic, non-hypertensive.
And her complaint is?
Complaint is the voice is very weak. You
That's
can
the only
listen.
complaint.
That is the only complaint.
No problem with eating and drinking.
No,
No problem with breathing.
no problem.
I
with
want to
breathing.
hear her voice. Ask her to count some.
नाम बताइए या 1 2 3 4 गिनती गिनोगी अम्मा? बोलो ना, बोलो कुछ बोलो तो.
बोलो बोलो देवी
नाम बताओ नाम.
बोले पर बरका दाऊदा
आपका नाम क्या है?
मैं बोला देवी
महबाना देवी.
बोला देवी
Has she got a hearing problem?
No.
Because that is also important. Hearing problem can actually affect voice.
देवी बोला देवी
Vimala Devi. You see, the speech is not very clear.
That's what she is telling. But speech is clear.
No, but the Vimla Devi
Ah.
usually says, they say Vimla Devi, but she is saying Vimala Devi.
Like that.
बोला देवी
Ask her to count 1, 1, 2, 3.
गिनती गिनो 1 से लेकर.
1,
1 2 3 4 5 6 7 8 9 10 11 12
that may be an articulation problem. That may not be a voice problem. Right. Let me see the tongue now. Is there a light?
Yeah.
Or give me the scope. Give me the scope. Give me the Savilon. It is quite dried up. So what I am looking for is any fasciculation.
Or MND.
As such, nothing. There is an atrophy of the mucosa. Ask her to stick out the tongue out.
जीभ बाहर निकालो. अम्मा जीभ बाहर निकालो. ऐसे, हाँ.
Move the tongue from side to side.
ये जीभ इस तरफ लाओ, साइड में लाओ, इधर. जीभ को लाओ.
Outside.
बाहर लाओ, बाहर लाओ.
Outside and
बोलो ना.
move outside to side.
बोलो ना. दिखाओ ना अपना.
Right.
Ah.
That is good. That is good enough for her age.
She is moving.
That is moving. There is no fasciculation. Okay, that's okay. No fasciculation. Okay, cool. No much fasciculation. There is something about her. Ask her to say ah.
बोलो.
She doesn't understand everything perfect, Gary. Okay, palate is normal. You can see both palate are moving right and left. Okay, that is fine. That's okay. Okay. You're right. Okay. So is she talking about a slurring of speech or a voice problem? What
That
she
is
talking?
not clearing of, I mean, clarity is not good. There is more articulation problem because
I
of
think
our
it is
age.
more of an articulation problem rather than. Okay, ask her to count again. 1, 2, 3. 1. Slow. 1. No. She's doing something else, no? Is she counting? 1, 2, 3. She doesn't get it. I think there is a problem with hearing also, and I don't think she actually get it. No, I don't think she gets it correct. It is not because of my Hindi, it is. She has a problem. She doesn't actually sense everything properly. I don't think. What is she taking?
Okay.
She's speaking something. Ask her what is her complaint.
क्या बोल रही अम्मा बताओ बोलो
She doesn't get.
वो पूछ रही क्या बोले एक्चुअली में द कंप्लेन ऑफ देयर अटेंडेंट आल्सो दैट द क्लियरिंग ऑफ वॉइस इज नॉट देयर दो शी मे स्पीक लिटिल लाउडर एंड द वॉइस इज क्लियर but sometime because of the less
It is not.
Our
She
field.
obviously will have a presbylarynx atrophy there because that is a high pitch sound is there. But it is more of an articulation problem than a
Than the
voice
speech
problem.
Okay.
Right.
आ जाओ
Okay, right.
so she will see to some vocalogist if it is available.
We have to get her hearing done properly,
Okay.
whether it is correct or not, and she understands. Okay, right, Amma.
So coming back to the Botox thing once again,
Yeah.
out of the 50 unit vial, you use just 5 units. So
Yeah.
what happens to the remaining 45?
That's a problem. There is so the best way is that you become friendly with the neurologist in your hospital.
Okay.
They use massive dose, so they will even give you free 5 units. 5 unit is throwaway for them, no? That will be
Okay.
the easiest way. But even actually, if you after reconstituting, if you can keep between 4 degree and 8 degree, you can use it for 6 weeks.
Basically, you can keep it in the refrigerator and that will
Yeah,
maintain
between, but don't freeze it. Between 4 degree and 8 degree, if you can keep it, you can use it for 6 weeks.
Okay, right. Thank you.
Who is the next patient?
Next patient is referred by Dr. Navneet Jain from Indore. I am
Yeah.
not having his history. So Navneet Jain is there in the crowd. I think we will ask him. He will tell. आइए नहीं बुला लो
Dr. Navneet Jain has just stepped out. I think I'll call him.
अच्छा no problem. Then you sit. We will see. इधर आ जाओ दादा क्या काम करते हो भैया हाँ, इधर उस
Face
तरफ
me
मुड़ के।
this way, this way, this way. Ah.
He is a farmer basically.
Ah.
He is having अगर ज्यादा बोलते हो तो गला खराब हो जाता है ऐसा
बोलने में मतलब गला दर्द करता थोड़ा और खराश आती है और मतलब खराश आने
Can you give the mic to the patient?
गला सूखता है थोड़ी देर बोलेंगे तो गला सूखता है पानी
dryness of the throat. He has to take frequent sips of water whenever he want to speak. And there is a lot of irritation in the throat. That is what.
But not true hoarseness.
गला सूखता है सर मेरा बोलने के ऊपर थोड़ी देर बोलूंगा तो गला सूखेगा और दर्द होएगा और खराश आएगी
Dryness, pain and irritation.
रात भर सो के उठता हूँ तो सुबह कुछ भी मालूम नहीं पड़ता कि अच्छा है लग रहा है ऐसा है थोड़ी देर बोलने के बाद दिक्कत होती है अभी मैंने नवनीत सर का जो जैन साहब का इलाज चला है 10 दिन की दवाई गोली ली है उसमें थोड़ा सा आराम मेरे को लगा है उसके पहले दूसरे डॉक्टर का इलाज चला था उस पर एक नया पैसा का भी आराम नहीं हुआ 1% भी
Morning he is having good voice, but as the day progresses, he is having
Problem with the moral. But is it a problem with him, or does the listener say that he has got a voice problem, or he also feel that?
आपको ये ऐसा लगता भैया कि जो सुनने वाले वही बोलते कि आवाज कुछ बदल गई आपकी कुछ प्रॉब्लम है
नहीं आवाज में प्रॉब्लम नहीं आवाज तो मेरी यही सी है आवाज तो खुली है मेरी आवाज में कोई
Voice
दिक्कत नहीं
doesn't
है
have a problem. No, he has got irritation of the
सिर
throat.
पे बोलने पे दर्द होता है मेरे को थोड़ी देर बोलूंगा ना ज़्यादा देर बोलने में आएगा तो मेरे को दर्द होता है, खराश आएगी और सूज आएगा।
And no breathing difficulty, no eating and drinking problem.
बाकी आपको कोई खाने पीने में कोई तकलीफ
नहीं, खाने पीने में कोई तकलीफ नहीं है, रोटी वोटी सब खा रहा हूँ, कोई तकलीफ नहीं होती, सिर्फ बोलने पे तकलीफ होती है। नहीं, नशा नाम नहीं करता हूँ, कुछ भी नहीं करते।
No drinks, no
नहीं,
smoking.
हाँ।
So he has got a problem of irritation of the throat. He doesn't have true hoarseness. He doesn't have breathing difficulty. He doesn't have swallowing problem, right? He's not a smoker. He's not a person who uses alcohol. Any idea he's snoring?
खराड़े आते हैं रात को सोते वक्त?
खराटे, हाँ खराटे आते हैं।
He is a snorer.
He is a snorer. And what is his weight?
वजन कितना रहेगा?
वजन मेरा 90
90 kg. And what is the height?
91 है।
Height I think 6 feet height होगी?
No.
Height कितनी है?
हाँ है।
6 feet.
He's 6 feet. Right. So he is a little bit overweight and does he have a daytime sleepiness?
दिन में तो नहीं नींद आती है कोई काम करते वक्त, टीवी देखते वक्त या कुछ जब बैठे होते?
नहीं, जैसे दिन में नींद नहीं आती है, शाम को टाइम अगर जल्दी खाना खा लेता हूँ तो फिर नींद आती है।
शाम को कितने बजे?
शाम को ऐसे मैं अधिकतर खाना खाता हूँ 9 साढ़े 9 बजे, और कभी जल्दी खा लेता हूँ तो फिर नींद जल्दी सताने लग जाती है।
Evening after meals he have some sort of sleepiness but not in the daytime.
Not in the daytime, right? And he is good. And he is not a hypothyroid guy, you know.
थायराइड की कोई गिल्लड़ की दवाई चलती है ये इसकी?
नहीं।
Is he on any regular
अभी
medicines?
कोई दवाई नहीं है, अभी सिर्फ मैंने 10 दिन की दवाई गोलियाँ ली थी, वो दवाई गोलियाँ खत्म हो गई।
कौन सी?
वो फाइल में सब लिखी हुई है।
अच्छा, वो for this condition only he is on medication.
Medicine, nothing. Does he suffer from tummy upset, gastric problem?
Gastric पेट में कोई दिक्कत आती है, गैस वगैरह, एसिडिटी
गैस वगैरह एसिडिटी तो नहीं बनती है, लेकिन मेरे को पाइल्स वगैरह की दिक्कत थी, तो पेट साफ मतलब 2-4 दिन में थोड़ी बहुत पेट साफ की दवाई लेता हूँ तो फिर दस्त से साफ होता है।
So he is having hemorrhoids problem, so just on
Other than that, nothing.
laxative he is having. So.
Right. Okay. Right. 10. So it's sort of a irritation of the throat complaint. So no true laryngeal complaint, like the major 4 complaints of larynx related are voice hoarseness, breathlessness, swallowing problem, cough. None of them are there. So his complaint is an irritation of the throat. That is also a very common complaint, because many times the larynx will be irritated depending upon their food habit, their acidity. So that is why I asked about the history of snoring. Snoring always causes dry. He's not a diabetic, no?
डायबिटिक शुगर की तो नहीं ना बीमारी है आपको?
नहीं, शुगर
no, not diabetic.
Nothing. So main things, sir, which actually cause drying is actually snoring, mouth breathing, diabetes, reflux. Reflux probably he has got because he's a little bit overweight, and snoring also may be there. We don't know the exact history because we need to ask his wife how bad is his sleep, whether he actually turn around, he has got apneic upset, we don't know. He may not be knowing that. He has got some increased daytime sleepiness. Nothing major. So the first thing is that look for anything abnormal in the neck. It looks all right. And look for the laryngeal crepitus. That is normal. The larynx is moving normally. Just, no, 1 minute. Show the light. Look, the oral cavity looks fine. Nothing. Maybe Malambati is slightly higher. Okay, right. Spray, please. Yeah. Jelly.
जैसे जैसे आपको बताएंगे ना वैसे वैसे आपने इंस्ट्रक्शन फॉलो करनी है, ठीक है?
बोलना तो
जब जो
हिंदी समझते हैं ना?
हाँ.
That's okay, no problem. Right. Ask him to breathe through the mouth.
मुंह से सांस लीजिए.
Keep the mouth open.
मुंह खोल के रखना और लंबा लंबा सांस खींचो अंदर.
पर है पीएनडी होगा. Deviated septum में levels पर है.
Now breathe through the nose.
हाँ, अब नाक से सांस लीजिए. नाक से सांस लीजिए, शाबाश.
Yeah, ask him to swallow.
गट को एक बारी गट को.
Swallow.
गट को अंदर. हाँ बस.
See, that his pharynx is little bit constricted. I am sure that he has got snoring. Whether he has got sleep apnea, I don't know. Maybe, may not be. That deal with it.
So, he had some CT done. Also, there is pharyngeal thickening is there.
Yeah, right. There's a pharyngeal narrowing is certainly there. I think he has got snoring sleep apnea, right? You see the arytenoid is quite edematous. Can you see that? The arytenoid mucosa is edematous, but that can happen in reflux. No, 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 no,
Ram
no.
se, Ram Chara ji, Ram
Say E.
E bolo, E.
Take breath.
लंबा सांस लेके E बोलो.
E. You can see the left arytenoid is overriding. Can you see that?
Yes. Sir.
Can you take?
Yes.
No, no.
बस
Don't continue. Just say E. E.
E. बस.
E. You can see both vocal cords are moving normally, but the left arytenoid is overriding. E. 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 Vocal cords are meeting in the midline. 30% of the normal population has got overriding of arytenoid. So in the absence of any voice symptom, overriding is not significant. So he has got overriding, and of those people who override, 90% of the overriding happens on the right side, 10% happen on the left side. He has got an overriding arytenoid E, and it's an edematous arytenoid. Now just let me see anterior commissure. I first thought I saw something there. There is lot of thick mucus. Ask him to cough out.
एक थोड़ा खांसो, हल्का सा मुंह पे हाथ रख के खांसी, हल्का सा खांसो. हाँ.
Again. Yeah, that mucus is now gone. Okay. Okay. Now say E.
E बोलो E.
E. E. E. Okay. Now what is there on the left side? E. 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 That is in the ventricle. No, don't do that. Don't do that. Don't do that. Don't do that.
आराम से बिल्कुल.
Like similar. Like
आराम से जैसे अभी थे ना 2 मिनट. हाँ बस relax.
That look like a cyst in the ventricle or ventricular prolapse. We will see now in a minute.
So which arytenoid is overriding? Left one is
Overriding. Left is overriding. E. See that left is coming in front of the right. That is how we override. Right. Now put the NBA. Put the NBA. Yeah. Don't swallow now. He's actually keeping on. Right. That is okay. That is okay. That's okay. Don't do anything. See that. That is a benign thing. Can you see that? That is actually just in the ventricle. Can you see the anterior part of the ventricle? Can you see that lesion there?
Yes.
Swallow. So it can be only two things. Either it is a ventricular prolapse, people who actually strain on the voice, or it is a small cyst in the ventricle, but it is not on the vocal cord. That is why his voice is okay.
So he has a significant DNS and we could see some postnasal discharge also. Could that be the reason for his frequent throat clearing and hawking sensation?
Maybe. That is also possible. The reflux is a common cause. Yeah. Let me see. I am just checking what is that lesion. If you look carefully, you can see that there is, even on the right side, there is a small ventricular prolapse. Say E. Now turn the head to the left. Yeah. E. Can you see that when it actually goes inward? E. See that? Then it comes out. Can you see that? So that's a prolapse. That's actually a ventricular prolapse. E. See, when he start taking breath, it actually go inward and then it come back. Watch again. Swallow. Say E. Watch that. Oh, he's swallowing so frequently. Don't swallow now. E. When he starts saying, you see that lesion. E. It will actually go inward. E. Can you see that? E. Yeah, that is a ventricular prolapse. This condition is known as ventricular prolapse. Ventricle is prolapsing. Yeah, cord is fine. That is why his voice is normal, right? E. Now ask him to produce a baby voice. E. That is not a baby voice. E. No. E. That is not a baby voice. No need of speaking, just say Hindi or English, doesn't matter. Ee. Ah, right, that is it. Ee. 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 See, vocal cords are okay. It is actually in the ventricle. See that the vocal cord is moving now. E, deep to it. E, e. See that is okay. Is he a smoker?
Cigarette पीते हो?
No, just treat him with anti-reflux medicine and postnasal drip treatment should be okay. That ventricular prolapse, he has got a ventricular prolapse on the left side, but that doesn't actually create much problem. His vocal cord is as such all right, and NBI. This is one important thing of NBI, you know. If you don't have an NBI, you can actually get confused whether this is a significant lesion or not. So NBI say it is a very uniform thing, so nothing to do with the neoplastic lesion or anything. You can safely say that it is actually a benign condition, nothing serious. You just keep him under observation and look out. But I think he has to be investigated for his snoring. That may be contributing. Now, as you told, the postnasal drip and the LPRD might be contributing to that. Nothing major, nothing serious. He doesn't have a voice issue, right? So we just need only vocal hygiene. Tell him that take enough water, don't clear the throat very frequently, take regular food habits, minimum 2 hours after dinner to sleep, all those things. So you can note that there is a small ventricular prolapse on the left side. Jaskaran can write left ventricular prolapse on the anterior part, but NBI wise absolutely no suspicious signs. And also, no, please note the overriding arytenoid on the left side. So we were talking about the overriding, no, right? So 30% of the normal people have got overriding arytenoid. So in the absence of a voice symptom, in the absence of a phonatory gap, in the absence of a vocal cord lesion, overriding arytenoid is actually normal. So now the correct terminology is that BAAA, that is benign arytenoid adduction asymmetry is the term we actually use. So BAAA, benign arytenoid adduction asymmetry. So if there is nothing wrong, leave it. And 90% of those people who have got adduction and overriding arytenoid happens on the right side, and 10% can happen on the left side. Yeah, what is the history?
क्या तकलीफ होती है आपको?
गला बैठ जाता है, बोलने में आता है।
बोलने में दिक्कत आती है?
गला बैठ जाता है आवाज।
So she has a voice problem, dampening of voice.
Hoarseness. She has got hoarseness.
बोलने में थकावट।
She's obviously hoarse. She can they can hear the voice in a way.
Can you give the mic to the patient?
इसमें माइक पे बात कीजिए.
बोलने में गला बैठ
That's a
जाता
rough
है
voice. Yeah.
और थकावट आ जाती है गले में।
Vocal fatigue she है.
How long?
कब से माताजी?
ये 2-3 महीने से।
2-3 months.
Only 3 months only. Before that it was
उसके
okay.
पहले कुछ नहीं था?
नहीं था कुछ भी।
How old is she?
और खाना खाने में कुछ भी दिक्कत नहीं आया।
नहीं, आवाज में 3 महीने पहले कोई दिक्कत नहीं थी?
नहीं थी कुछ भी।
So 3 months before nothing was.
वो बीच में ठीक भी हो गया था मेडिसिन से।
How old is she?
आपकी उम्र कितनी है?
मेरी 38।
38.
She has got small kids, children.
बच्चे हैं छोटे?
हाँ, 2 बच्चे हैं।
कितनी उम्र के हैं?
एक 18 का, एक 20 का।
2 kids, 1 18, 1 20.
Any other illness? High blood pressure, diabetes?
ब्लड प्रेशर, शुगर या और थायराइड की दवाई खा रहे हो कोई?
नहीं, बीपी लो हो जाता है।
लो ज़्यादा की दवाई खा रहे हो?
नहीं दवाई कुछ किसी की भी नहीं खा रहे।
नो ऑन नो मेडिकेशन।
She's a teacher or something like that or a housewife?
आप घर में हाउसवाइफ घर में रहते हो कि कोई जॉब करते हो, कोई काम करते हो?
नहीं घर में रहती हूँ।
हाउसवाइफ ओनली।
हाँ।
Can you ask her to do the MPD maximum?
आपने एक लंबा सांस लेना है और एक सांस में आपने ई बोलना है, जैसे मैं बोलूँगा मेरे पीछे बोलना है, वैसे ही आपने आवाज़ निकाली जब तक हो सके तब तक। जैसे देखो पहले मेरी तरफ देखना है, ई ऐसे, ठीक है, जब तक आप बोल पाओ। अब लंबा सांस खींचिए और अब बोलो।
Good, 10 seconds she reached. Now, audience, I don't know whether the camera has to be, can you see her very well, especially her neck region?
Yes, sir, we can see her.
You can see. Now, when she speaks, watch her neck blood vessel as well as the supraclavicular region, the region, and tell me what is happening. You ask her to count 1 to 10.
Just zoom it, just 2 minutes I'll zoom. ये कैमरा zoom कर बेटा।
Concentrate this area, the clavicle, the lower, this region you have to see. Can you see the clavicle here, both sides?
Yes.
And
yes.
you can see this is the cricoid cartilage, this is the thyroid cartilage, and this. Yeah, you can see that. And now ask her to count 1 to 10 or speak anything. Ask her history.
अभी ना आप 1 से लेकर 10 तक गिनो, गिनती करो 1 से 10 तक।
1 2 3 4 5 6 7 8।
Can you ask her to look up because we cannot see the
count
neck.
louder.
अब दोबारा से 1 से 10 तक है, थोड़ा सा ऐसे से रखो जैसे मैंने रखा है। आप बोलिए।
1 2 3 4 5 6 7 8 9 10।
Can you see that her root of the neck is bulging up here? Ask her to speak something. Take a history. Take a history.
आप बात जैसे अपनी तकलीफ मुझे डिटेल में बताइए, आपको दिक्कत आ क्या रही थी?
दिक्कत यही थी, बस गला बैठा था, कुछ भी दिक्कत नहीं थी।
Can you see that this is actually coming out? She's actually straining at her voice. She's forcing.
कुछ भी दिक्कत
Can you
नहीं
see
है
that
खाने
again?
पे। थोड़ा सूखापन
Can you see that each and she take neck breathing. That is very
लगता
important.
है गले में, वो मतलब थकावट आ जाती है बोलने में।
कितने बोलने के बाद थकावट आती है?
थोड़ी देर।
See that it bulge out. And each time she take neck breathing. She's a fast speaker. Rather than the chest breathing, she's actually taking neck breath. Once again, watch it. Tell. And how long she has been having this problem?
आपको ना कब से ये तकलीफ आ रही है?
ये तो अभी आने लगी।
See that she's actually using only the neck for breathing.
पहले तो गले ही बैठा था।
See that? Can you see that my finger is being
मेडिसिन चली
pushed up?
और फिर उसके बाद
And
थोड़ी
can you see the
सूखापन आने लगा,
external jugular vein becoming more
थकावट
prominent?
आने लगी।
Can you see this?
आप अपनी बात करते जाइए।
The more of a subglottic pressure at every.
Can you see the external jugular vein becoming more?
Yes, sir. Yes, sir. Yes.
She's actually forcing. She has got forcing. She has got fast speaking. She has got neck breathing. They all are, creators. That's a recipe for vocal nodule. People, ladies who speak very fast, they have got neck breathing. They force the voice. They are actually putting the vocal cord at strain, and they typically develop vocal nodule. We will see now. So whether it is a nodule or a polyp or a cyst, we will see, because they develop sprayed. Stroke बना।
तो आधे मिनट 1 मिनट में ठीक हो जाएगा, घबराना नहीं है, कुछ नहीं करेंगे, बहुत पतली से दूरबीन का जांच होना है, कोई डरने की बात नहीं है, ठीक है? बस ऐसे एक बारी और, बस और कुछ नहीं, अभी लंबा सांस लीजिए।
She's very worried. Tell her that nothing to worry. This is nothing.
ऐसे घबराना नहीं है, बहुत ही पतली दूरबीन का टेस्ट है, आधे मिनट में खत्म हो जाएगा, ठीक है? घबराओ बिल्कुल नहीं, कुछ नहीं है, हम इधर ही आपके साथ हैं।
Cool down. Wait. Let the anesthesia take. She is very nervous person.
अरे डरने की बात नहीं है।
She will fall down.
घबराहट हो रही है?
I think she is so nervous a person. Yeah, right.
She's having vasovagal. एक मिनट रुको, कुछ नहीं, इधर रखो टांगे अपनी, इधर रखो, इसके ऊपर रखो, लात रखो, शाबाश। सिर थोड़ा पीछे कर लो, बस।
She is such an. See, that's also typical personality behavior, because of most of the vocal nodule people, they will be very nervous. They are fast speaking. They typically they speak fast.
बस चक्कर आ रहा है?
No, no, only when she's okay, yes.
अगर नहीं ठीक था
She's
तो
so
बता।
worried about, she doesn't understand what problem is going on, so he's nervous, so nervous. Tell her, explain that it is
देखो,
nothing.
आपको होना कुछ नहीं है, ये बहुत ही पतली दूरबीन है, छोटे बच्चों में
It
की
won't
दूरबीन
hurt,
है ये,
no
ठीक है?
pain.
आपको कोई तकलीफ नहीं होगी, कोई दर्द नहीं होगा, कुछ भी नहीं होगा। आधा मिनट से भी कम टाइम डॉक्टर साहब ने देखना है, आपको कुछ होगा नहीं, आप कोऑपरेट करना है। अगर आप ज़्यादा तकलीफ या मुश्किल होगी, हम प्रोसीजर बंद कर देंगे, आपको और तकलीफ नहीं देंगे, ठीक है? आधे मिनट से भी कम टाइम लगेगा, कोई पेन, कोई दर्द नहीं होगा।
जल्दी निकाल लीजिए।
जब आप कहेंगे तब निकालेंगे, पर हमें देखने दीजिए अंदर बीमारी को, ठीक है?
You can see that, you can listen to her voice, it is very scratchy type of voice. She speaks very fast. She put lot of effort, the neck root is bulging. She's a very nervous person. They all are typical features of vocal nodule, no? The people who actually, they're very hyper sort of thing, lot of people. She's so anxious now, even now. Tell her that it is nothing, she's so tense, don't worry, ask her.
ऐसे ना, इधर आपका थोड़ा shoulder से जाता है, so she's sweating actually.
Yes. Is she okay?
I think
Is she okay or she will fall down? I don't know. She is not very. Is she okay? I don't know.
So she's actually, clinically she is like sweating. I think we should wait for her.
Yeah, yeah. Or she lie down. They.
माता जी आइए, आप उठ जाओ।
She,
2 मिनट बैठो।
take out that.
आप 2 मिनट बाद इधर बैठ जाओ।
You know, make her lie down. We can do it on the.
इधर लेट जाओ, 2 मिनट इसको ना लेटा दो। लेटाओ।
No, no, we didn't do the scope. Before that, she actually fell down. Not fell down. Yeah. Okay.
Is a patient who has got history of stroke on 17th February.
Yeah.
And on 18th, he has got carotid stenting.
Yeah.
So he recovered completely and he can produce voice, but tongue movement, the articulation problem is there. So I just, he is coming from Anup Nagar, that is a far-flung place. And one of the doctor has sent this patient that if Jaykumar can see, then something has to be done for his voice.
So it is mainly about, what is your name? No, this is aphasia, that is not related to larynx.
Not related to that.
Aphasia, that is a brain problem. It's not related to the vocal cord. She cannot speak. He's not telling that. It's an aphasia sort of thing. It is not related to the voice. Can you count 1 to 10? That's not a laryngeal issue.
Okay.
That's a cortical issue.
Aye.
You need a speech therapy, continuous stimulation of the thing. So this is not the voice therapy. He's the person who require regular voice. What kind of stroke it was? MCA. Where was the stroke? The stroke region, brain, in which part of the brain they heard the stroke? There must be a detail. What the neurologist has written?
And carotid stenting was done.
Yeah, yeah. So maybe it is a middle cerebral artery stroke. Did he have a swallowing problem in the beginning?
शुरुआत में जब आप खाना वाना खाते थे तो तकलीफ थी क्या? नहीं. No problem in eating.
Yeah.
No problem in
So it's a
swallowing.
frontal cortex then. It's a Broca's area problem. What they have written? MCA stroke. So MCA territory, anterior branch might have gone. So this is not a laryngeal issue.
Okay, then he has to go for
Persistent speech therapy, because the brain, the part which is controlling the speech, the Broca's area is not really working very well. He understands everything, right?
Yes.
But he cannot produce it back, right? So that is a motor aphasia.
So if there is any center in India for where we can send him for that motor training?
Nimhans will be a very good center.
Bangalore. Okay, I will explain them. आइए. Next patient को लाओ.
No, cortical thing, the maximum swallowing issue is not as the swallowing apraxia. They will not be, they swallowing will be normal, but they may not eat. But he doesn't have any issue. It's okay.
ठीक है माता जी, अब ऐसे बेटा अभी 2 मिनट ऐसे रुको।
Okay, put that jelly. So tell her every step, otherwise she will get scared.
मैं एक एक जो मैं करता डॉक्टर साहब करे मैं आपको बताता जा रहा हूँ अपने नाक में आपके हल्का सा स्कोप जाएगा
Tell her that it won't hurt.
हल्का सा
Ask her to breathe through the mouth.
चुभन होगी अभी इसके बाद आप मुंह से सांस लीजिए शाबाश दो बड़ा खोल के सांस लीजिए आराम से
जसकरण आप थोड़ा व्यू में आ रहे हैं प्लीज थैंक यू
और अभी आपने थोड़ा
Now breathe through the nose.
अभी नाक से ब्रीथ कीजिए शाबाश
Swallow.
अब ना गट को बेटा गट को शाबाश गट को गटक ले एक और गट को शाबाश बस
Yeah, say. Swallow. Yeah.
गला साफ कीजिए
Yeah. Okay. Now put on the strobe. Yeah. Louder.
जोर की बोलिए पूरा आवाज लगा के ये बोले
Can see the good mucosal wave. Can you see that? See that the mucosal wave? Louder.
जोर की बोले पूरा जोर लगा के बोलो
Can you see the mucosal wave? There is early nodule both side, actually left is bigger, so there was a doubt that whether the left lesion was a cyst, but you can see that there is a good mucosal wave. Can you see the mucosal wave?
Yes, sir, yes. Sir, does she have a sulcus also?
Yeah, that, grade 1.
Yeah.
That's a small thing. I don't think that is important. You see that longitudinal thing, you know. So when you see something like that, always put NBI. So you can see whether it is a sulcus or a blood vessel. NBI. No. See that. No, like.
आधा सेकंड लगेगा आधा सेकंड
See, that was a blood vessel. This is a common mistake. Many times a longitudinal blood vessel will be seen as a grade 1 sulcus. So when you're in doubt, you put on the NBI. NBI will actually highlight the blood vessel. And you can see that nodular thickening on both sides, more on the left. There is a suspicion that it could be an early cyst. There is a slight whitish change. Can you see that?
Yes, sir.
Yeah, but mucosal waves are very good. It's okay. She's too nervous a person. Yeah, right. She need only voice therapy right now. If it doesn't work, only no, wait. She's so nervous a person. Yeah, right. Yeah. So the problem is that this kind of ladies are actually very difficult to treat because to follow voice therapy, you need lot of understanding and the thing. This kind of people are very, very difficult. They don't understand. They will have the concept that for every illness, the treatment is a sort of a medicine or a surgery. So to tell that vocal nodule requires surgery, voice therapy, unless they are a voice user, they are not going to utilize it properly. Here the basic problem is that he talks very fast. So people who speak very fast have got neck breathing and they will develop vocal nodule. So to correct her, if she follows therapy, great. If it doesn't, then think about exercising the vocal nodule. But if she continue the same thing, nodule will keep on coming back. Huh? It's a vocal nodule, type 1 muscle tension dysphonia, left bigger than the right, good mucosal wave. Plan voice therapy. If it doesn't respond, you can think about decompressing, but that is not the standard treatment.
Sir, this patient has got nasal twang in her voice.
Got what?
Nasal twang.
Okay.
And I think she might be having some cleft, soft cleft.
Submucous cleft.
Submucous cleft.
How old is she?
कितने साल की हो बेटा?
94.
How many? 24. Tell me your name.
Nina Manu.
Okay, count 1 to 10. 1, 1,
2, 3,
Ah.
4, 5, 6, 7, 8, 9, 10.
That's typical hypernasal voice. So she tell 1, 2, 3 like that. And Hindi, 1, 2.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
So not only hypernasality, because he also has got misarticulation. That is common with a cleft palate. Give me the light. So this must be a submucous cleft because she doesn't have an obvious cleft. Open the mouth. Now you can give me the watch the palate. No. Wait. Yeah. Clean. Clean the tip. Yeah. No, don't go back to it. Don't. So what are the signs of cleft palate? One is the submucous is the bifidobula. It is not there. There is probably a dip at the junction of the hard and soft palate. So here there is two more exercise. One is actually palpate, that I will do at the end, but I will do a nasal endoscopy to see whether there is a submucous cleft. Spray the nose.
वो परेशान मत हो बेटी, है ना, देखने दो.
Tell
I
her,
think,
these people, they get nervous because it is very stinging. So unless you tell them, they get worried.
उस तरफ सर की तरफ मुंह करो बेटा.
She's so nervous. All these people are very nervous. Tell them that it is nothing to. Nothing. You don't have pain. Cool down. There is no pain. Is she working or a house or something like that? What is she doing? Relax, daughter. It is not pain. There is no pain. Nothing. Keep your hand in your. Here, cool down. It is nothing. No pain. Absolutely no pain. Don't worry. Tell her that I am going to see. It won't hurt. It is not painful or anything. Yeah. Look. She's so nervous. She's so scared.
अरे बेटा,
Don't get
अरे
scared.
दिखाओगी नहीं तो फिर जाओ, फिर क्यों आई बेटा तुम?
She's so
तुमको
scared.
बताया था ना कि डॉक्टर साहब से दिखवाएंगे तभी तो अच्छा होगा आवाज तुम्हारा. चलो दिखाओ.
Relax.
बिल्कुल रिलैक्स हो जाओ.
She
शाबाश.
doesn't understand. Why are you so tense? Nothing. Cool down. Lean forward. Lean forward.
वेरी गुड. आगे झुको. शाबाश.
Cool down. Don't worry. It's not painful.
चल रही साइड में. वेरी गुड.
Keep the mouth open and
मुंह खोल लो बेटा, मुंह खोल लो. बस.
not too much.
पीछे मत जाओ.
She is too nervous a person. She is so scared. No. Yeah. She doesn't understand anything. She is actually so nervous. Right? She doesn't understand anything what she talking.
हाँ.
It's not painful. Don't worry. That nothing. Cool down. Right.
अभी नाक में जाएगा हल्का सा, कुछ नहीं है. मुंह खोलो, शाबाश. आराम से सांस ले. हाँ, खत्म.
Don't.
पीछे मत जा. हाथ ऐसे. शाबाश. सांस लेते जा. नीचे देख बेटा, थोड़ा सा नीचे देख. कुछ भी नहीं होगा.
She is doing
हाथ
lot
पकड़
of
ले.
things.
चल, शाबाश.
What are you doing? You just relax, girl. Right? Nothing. Yeah. Right. That is. Oh, don't go.
हो गया बेटा. हो गया.
हाँ, बस.
हो गया.
अब नाक से सांस ले, शाबाश.
No. Now say ah. Now if you can see, I don't know. For normally at the level of uvula there will be a convexity. That is known as a musculus uvulae bulge. Here it is flat. Can you see the dorsum
Yeah.
of the entire soft palate is flat?
Yes,
Normal person there will be a bulge, tongue-like bulge in the middle part. Here it is. You can see that from right to left it is a flat surface. This is
Yes.
a typical sign of submucous cleft. Now say ah again. ah, ah, and always test with fricative sound, S and F. Ask her to say,
जैसे डॉक्टर ने आवाज
see that, can you see air leaking?
Yes, yes, yes.
See again, can you see that? See that? That is typical of a submucous cleft. There is it is not closing completely. So these two signs, see that? This is a totally flat. Now next time I will do the scopy, I will show how the normal palate look like. So these two signs, flat dorsum of the palate and the air is leaking there. If there is a little bit of saliva, you will see the bubble coming up between the palate and the posterior pharyngeal wall. So this is a typical submucous cleft. So that should be treated just like a cleft palate. So you have to refer to a plastic surgeon or a pediatric surgeon, whoever does the palate surgery here. So the problem here is that if you palpate, you will actually, you will get that notch. All these people are so nervous. Right. No, make, oh, she will fall down. She is that kind of a, no, make her lie down. Her head should be down. Few seconds, you'll be okay. Now, what is happening is that normally the palate, the palatal aponeurosis, that is levator palate and tensor palate come and meet like that. But the problem here is that when submucous cleft is there, they go like this and get attached to the posterior border of the hard palate. So they don't actually meet together here. This is a problem with the submucous cleft. So they will have very bad palatal function like that. So this has to be corrected. So it is exactly like a cleft palate surgery. They will open up, they will identify the sling, detach from the hard palate, bring it transversely and repair. When they interdigitate the tensor palate and levator palate, you will get that musculosubular bulge and palate will be okay. So she will have an excellent result if it is done properly by a plastic surgeon or a...
Sir, whether sometimes they say that the nasal twang which is there for so long, even if you do the surgery, the brain doesn't...
No, it will improve.
It will improve.
Misarticulation, you may require speech therapy. Some letters she has learned wrong, but this will become okay.
Okay.
No, that is when you have done a cleft palate surgery, even after the repair, there is a gap. Then you do the filler. There are a lot of surgeries like sphincter pharyngoplasty, pharyngeal flap repair, all of things. But this is the standard case for a cleft palate repair. She will have excellent results.
So this lady has got bad voice or the hoarse voice since last 4 months.
Yeah.
That is the only problem.
So what is her voice like?
अपना नाम बताइए.
शिकाला बंसी.
कहाँ रहती है?
ब्लेसल कनी.
और कितने बच्चे हैं आपको?
2.
पति का नाम क्या है?
अनिल बंसी.
He is trained lot of and voice is off.
And how long?
Since 6 months.
Only. Before that her voice was normal.
4 महीने पहले बिल्कुल अच्छी थी.
हाँ ठीक थी.
She is a housewife or she has got a job?
आप जॉब करती कि हाउसवाइफ हैं?
हाउसवाइफ.
Housewife. And
कितने बच्चे हैं?
2 हैं.
चिल्लाती ज़्यादा हो?
हाँ चिल्लाते बच्चे ज़्यादा.
And she doesn't have any swallowing or breathing dysfunction.
बाकी सांस लेने में और उसमें
नहीं कुछ दिक्कत नहीं आ रही.
No other illness.
डायबिटीज ब्लड प्रेशर
कुछ नहीं.
Menstrual periods are normal.
आपका जो एमसी आता है मासिक धर्म सही आता है?
हाँ सही आता.
Now again, just like the previous patient, watch her neck when she speak. You will see that she has got she has got a neck breathing. She speaks fast. She bulges her neck. Everything typical of a nodule type of thing.
बोलो अच्छे से कुछ बताओ बात करके बताओ बोलो नाम बताओ अपना.
शिकाला बंसी.
Can you see the root bulging? Count 1.
शिकाला बंसी.
See that each time it will push my finger out.
गिनती गिनो 1 2 3 4.
1 2 3 4 5 6 7 8 9 10.
And see that habit. She finished everything in 1 single second. She is a fast speaker. She is a fast speaker. We always get vocal nodules. She take neck breathing. Ask her to count up to 20. 1 to 10. 1
तक गिनो 1 से 20 तक गिनो.
1 2 3 4 5 6 7 8 9 10.
No, up to 20.
20 तक लगातार गिनना है.
1 2 3 4 5 6 7 8 9 10 11 12 13.
See that? See,
so we can't-
she speaks so fast, she want to finish off everything in one single breath, and so those people actually develop what is known as the neck breathing. So they will speak like that. They don't have chest breathing. So typically ladies who speak very fast, they have got a very poor breathing technique. Their neck breathing is so bad. So normally a tidal volume is 500 ml when somebody speaks with a chest breathing. When somebody speaks with a neck breathing, they have got 150 ml and they invariably develop vocal nodule. So this is the key in vocal nodule. If you don't correct that breathing habit, nothing will actually correct the vocal nodule. They will always have. The problem is motivation. So a person who is a singer, who is a voice user, a teacher will actually listen to you. A housewife is very unlikely to respond, or they think that okay what, because they want shortcuts, it's just a medicine for the vocal nodule. It's not going to disappear. I haven't done a scopy, but most likely she has got a vocal nodule. Maybe she has got a grade 1 sulcus. We will see.
Okay.
Yeah.
बेटा आपकी ना नाक में पहले एक स्प्रे घबराना नहीं।
करवा चुकी ना पहले एंडोस्कोपी।
मेरी बात पहले ध्यान से सुनो, पहले मेरी बात ध्यान से सुनो। छोटा सा
And all
स्प्रे
these
होगा।
people will be invariably nervous
उसके बाद
personalities.
आपका नाक सुन्न हो जाएगा। ठीक है, कोई तकलीफ
They will be
नहीं होगा।
scared of almost everything.
बिल्कुल पतला सा धागे जैसा दूरबीन है, लेकिन कोई आपको तकलीफ नहीं देगा, कोई दर्द नहीं होगा। ठीक है, ये दवाई हल्की सी कड़वी लगेगी, इसके अलावा इसका भी कुछ इफेक्ट आपको मुश्किल आएगी। तो आप आधे सेकंड के लिए कोऑपरेट करना है, उछलना नहीं है। जो आपको समझाएंगे हमारे इंस्ट्रक्शन फॉलो करना है। अभी देख फिर आप
See the typical another behavior. She's so nervous. All these vocal nodule people will be this kind of personality. They will be very nervous. They will be very anxious. They speak like they are going to finish off everything in a minute.
तो उससे भी अच्छा है, हटो आ जाओ सामने, पहले स्प्रे करो, कराया तो हमने, करो ना करो।
So almost see that's an unusual behavior. Like say nervous people, they are very very nervous people.
हो गया वो खत्म, आ जाओ।
They get so scared. They got everything. So it's a type of personalities only actually develop vocal nodule. Not everybody will actually. Every teacher doesn't develop a vocal nodule. People who speaks very fast, who actually finishes off everything in a thing. They speak lot. They don't have time to relax. They don't stop talking. They got the nervous, anxious personality. They all are typical of an vocal nodule people. No, they generally develop. Occasionally it can also happen with overwork that happens in a teacher or a singer, but generally this is the behavior, and the key is always bad breathing technique, and they invariably have neck breathing. So this is the chest breathing. Somebody when I speak, you can see that in between my chest expand, and adults are males, you may have an even very good abdominal breathing. See that when I talk 1 2 3 4, see my abdomen comes out. They are very very powerful breathing technique. Vocal cord hardly ever get into trouble. But people who speak fast, they like that. They take 1 2 3 4 5 6 7. So the very little air get into the chest, and the air which actually needed to vibrate the vocal cord is so less in the amount. Consequently, the vocal cord undergo lot of tension and they develop vocal nodule. So the key to voice therapy in vocal nodule is cut down the speed. Easily said than done. Most people won't do it because this has been the habit. It is like a computer, like a default setting. Once the default setting is corrected, you have to write a new program. Importantly, you have to save the program. That is why voice therapy for a vocal nodule is so difficult, because you will tell that okay, you speak slowly. They will speak in front of you slowly. But when they go home, they will again speak wrong, and then they will tell that no improvement. How it can improve? It will not improve. So usually, this is from my experience, vocal nodule people will get better only they are professional voice users, because they understand they are important. They are very very bothered about their voice. Vast majority of the lay people, they don't actually listen to your counseling. They will tell okay, they will expect shortcut remedies, medicine, give you medicine. You can give steroid, but that doesn't cure it. We'll see. Yeah, stroke. Tell her that it is not painful. The way she sit itself is, actually she is so worried.
बेटा मेरी बात सुन, कोई तकलीफ नहीं होगा, ठीक है? उछलना नहीं है, बिल्कुल भी आराम से होगा, बहुत पतली सी दूरबीन है।
It won't be. Look at she's so tense.
चलो करिए सर, प्लीज गो अहेड।
She's so worried about all these things. It's
अरे भाई 1 मिनट में हो जाएगा। वेरी गुड, आराम से सांस लो।
slow. Don't do anything. Now say ah. Can you say ah, ah? Louder. I'm just showing that bulger
Yes.
See that
Which was not there in.
center part is convex. Can you see here?
Yes, yes.
Yeah.
Submucous palate.
Yeah, breathe through the nose now. Breathe through the nose. Breathe through the nose. Breathe through the nose.
Naak se saans lo,
No,
naak
no,
se.
she's kind of. Yeah, breathe through nothing. Nothing, nothing. Yeah. Ask her to say. Take breath. She's going back. Ask her to swallow. Slow down, madam. Don't do.
आराम से हो गया, बस जांच पूरी हो गई.
Say E now. Take breath, take breath. Take breath, take breath, take.
लंबा सांस लो.
Take breath, take breath, take breath. See the nodule there? At the junction of the anterior one third and middle third, irregularity here. You can see different kind of nodule. You know, like, and there is some amount of whitish keratinization also is there. Put the NBA. Put the NBA. See that? Yeah, that's a keratinization. That's lot of, and you can see as maybe there is a small grade 1 sulcus maybe there. See that keratinization? Can you see there? That is purely white. There is absolutely nothing. See that? Can you see that white color on the side?
Yes,
On the
sir.
NBA.
Yes, sir.
That's a keratinized nodule. That's a longitude. You know, you need not always get very sharp nodule. Now cut off the NBA and put the strobe.
So it is on left side, no?
Yeah, left side, left side.
And
say-
on right side also there is a development.
There is a day. Yeah. Say E now. E. See that good mucosal wave. E. Can you see the mucosal wave and can you see the
Yes, sir.
hourglass shape phonatory gap? Anterior and posterior to the vocal nodule region, there is a gap. Say E. No, normally, what are you telling? Can you see that?
Yes, sir.
In
Yes,
the
sir.
middle there is a E. Anterior and posterior there is a small gap. Can you see that?
Yes, sir.
That's typical because there is a small thickening. So that's a sort of a polypoidal broad nodule, typical type 1 muscle tension dysphonia. So the treatment plan is actually counseling, telling that it is nothing serious, but unless you develop unless you reduce your speed of speech and don't talk more than 8 hours, it is problem. And another advice you can give is that I don't know how many will actually. Unlike male voice 30 days a month is same. Female voice unfortunately is not like that. Estrogen is a hormone which support the voice. Progesterone is the hormone which make the voice bad. So a lady with a regular menstrual cycle will have always problem during the progesterone phase. So they should understand it. So 3 to 4 days prior to the periods and first 2-3 days of the period of a week period, actually progesterone is high. And when the progesterone is high, the vocal cord is edematous, is more likely to get injury, more likely to get bleed, and more importantly, we all know that when during progesterone phase, they will be irritable. They are likely to shout at the top of their voice. They will get angry with their children, their husband, or if they are a teacher with the students, all these things. So coupled with these two factors, they got water retention of the vocal cord and they got mood change. So during progesterone phase, the vocal cord get damaged in a lady. So an educated person, if you instruct them very correctly, they will be okay. Face this way, madam. 10. Yeah. What? Yeah.
There is lax lower esophageal grade 3, and esophagitis is there.
Yeah.
And there is also multiple cystine polyps were there in the stomach, which they removed.
Yeah.
H. pylori was positive, and HP उसके ज़्यादा हुआ कब इंजेक्शन so she already had injection earlier. So आपको तकलीफ क्या आता है?
Spasmodic dysphonia, Botox. She had Botox.
इसमें बताइए क्या तकलीफ आता है आपको?
बोलने में आवाज अटकती है और कुछ शब्द गायब होते हैं और मतलब भारी आवाज है.
You had some voice disorders. तो पहले कितना टाइम पहले इंजेक्शन पिछली बार लगा था?
करीब इसमें 1 आध साल हो गई.
That's typical spasmodic dysphonia voice. You can hear that voice. Can you pick up that voice? That is a spasmodic. Ask her to tell her complaint.
आप ना दोबारा अपनी सारी शुरू से कंप्लेंट माइक में बताइए कि क्या क्या
Start, tell in detail. When did it start? When did it go?
कब स्टार्ट हुआ
जैसे बोलते हैं आवाज अटकती है, शब्द गायब होते हैं,
That's
ज्यादा
a
लंबा
typical adductor spasmodic dysphonia. Okay, go ahead.
और उसके अलावा
उसके अलावा
ये टेस्ट आपके जो हो रहे उसके बारे में कुछ बताइए। जो आपका पेट का टेस्ट हुआ था,
क्या
पेट का टेस्ट हुआ है ना,
हाँ।
उसके बारे में बताइए पूरा डिटेल में, क्या क्यों करवाया था आपने?
बस सर ने यही कराया था, यही हुआ था,
किस वजह से?
मतलब यही आवाज अटकने की
This is
वजह
that's
से।
a typical adductor spasm. When was the injection done?
लास्ट ईयर से।
And did it improve the voice temporarily?
उसके टेम्पररी कुछ आराम आया था,
कुछ भी नहीं,
आवाज कुछ फर्क नहीं आया आपको?
कुछ भी नहीं, बिल्कुल नहीं।
Even with the Botox, she didn't actually improve. Right. Ask her to do the MPD, full breath. What is her job?
आप काम क्या करते हैं?
हाउस वाइफ।
Yeah. Ask her to take deep breath and then
एक ना
say
लंबा
E
सांस
for as
कीजिए।
long as you can.
एक लंबा सांस लेना है और आपको देखो मेरी तरफ देखिए, लंबा सांस लेके ई बोलना जब तक आप बोल पाइए, ठीक है? शाबाश। इसमें लंबा सांस खींचो।
Not a mm.
ई
See, that's typical. The adductor spasm, MPD will be prolonged. Ask her to count 1, 2, 3.
1 2 3 हिंदी में बोलिए।
1 2 3 4 5 6 7 8 9 10 11
That's
12।
typical. Ask her to block one ear and speak.
एक कान में ना एक बंद कीजिए, उंगली लगाइए कान में, ऐसे बंद कीजिए।
Ah,
अब फिर से
now
बोलिए।
count. 1. No, 1, 2.
एक ही कान पे।
No, 1, 2, 3.
1 2 3 4 5 6 7 8 9 10 11
No,
12।
not much difference. Now, speaker with the baby voice like 1, 2,
बच्चे की आवाज बोलिए।
2 3
See,
4 5।
that is better. That's typical of a spasmodic dysphonia. With a falsetto voice, she will actually better. So her MPD is increased. She has got spasm. So even without looking at the vocal cord, we can see that. I don't know why she didn't. There are many reasons. One, it might not have gone into the vocal cord proper, but I don't know exact. Did ask her after the injection, did her voice become bad?
जब इंजेक्शन लगा था उसके बाद आपकी आवाज में कुछ
Bad.
नहीं फर्क की बात नहीं कर रहा हूँ,
हाँ।
खराबी आई थी? जैसी आवाज थी
जैसी है,
वैसी,
वैसी थी।
ना अच्छा हुआ ना बुरा हुआ।
Okay, so then there are two possibilities. Either the Botox didn't actually go to the vocal cord itself, or the injected Botox might not have been very potent. There are two reasons. Both are possibilities.
Are there any typical sentence we should ask patient to speak for diagnosing adductor and abductor?
Yeah, generally counting is okay. That's what abductor typically has got problem with fricative sound. Fricative means you force the voice through. Like the typical words will be F and S. So somebody who's got an abductor spasmodic dysphonia will have maximum difficulty for 4, 5, 6, 7. They will tell 4, 5, 6, 7. This is typical of an abductor. Adductor will tell 4, 5 like that. Say, SP, when did she have an injection daily? She told that she didn't have neither improvement nor thing. So there are only two possibilities, because it is definitely a spasmodic. Either the injection didn't go to the muscle, that is a possibility. Did we inject with the endoscope or with the LEMG? EMG was not here. Okay. Or second possibility is that Botox didn't have potency. The two possibilities are there, but it is typically a spasmodic dysphonia.
So this time I called her because either we can give one shot of injection because she doesn't, but I explained her also that now you have got another.
How old is she?
कितनी उम्र है आपकी? 66.
She is a diabetic.
She is a diabetic.
Controlled?
Controlled.
Right. And is she really bothered about that voice problem?
अब ये बताओ ये आवाज तुम्हें कितना परेशान करती, काम चल रहा है कि इसको ठीक करना है, सर्जरी करवाओगी क्या इसके लिए? आवाज जो है आपकी ये आपको बहुत परेशान कर रही है, ऐसी थोड़ा सा लगता है, क्योंकि क्या है कि अब इंजेक्शन बार बार लगाने से बेहतर है, क्योंकि उसका असर कम समय तक रहता है। आजकल एक नई सर्जरी आ गई है, डॉक्टर साहब ने आज ही डिस्कस किया इस बारे में, और काफ़ी सर्जरी कर चुके हैं, उसमें रिजल्ट अच्छा है। तो आप क्या सर्जरी कराना चाहोगी वो?
Yeah, that's what. There are three options in spasmodic dysphonia always. First, no treatment. Tell them that this is not a serious disorder, it's a nuisance disorder. Fine. If they are very keen about the voice, talk about two issues. One is a Botox, it has got its own problem. Every 6 months she has to inject. Sometimes, as he told, occasionally it might not work, sometimes it cannot work right. Third is that go for surgery. Surgery again, there are two choices. Either you go endoscopically or you go externally. So it is entirely the patient's choice. It's not a serious disorder. If patient is really bothered about, think about it.
I will explain her. One more patient is there.
Shall I do the scopy now for her?
Of course, people will see. अच्छा, एक और पेशेंट है सर, वन मोर पेशेंट इज देयर, वी विल कॉल हर। सतपति साहब को उनको लाओ। स्पॉजिट
Usually with the first injection that doesn't happen.
No,
That's a later happen. She had only first injection. So there are only two options. Either the needle didn't properly go to the that can even happen with the most experienced people, but that chance will be less with an EMG. When you are doing with an EMG, you know that the muscle activity will be very bad. Second is that sometimes some of the brands may not have enough potency. That also can happen.
Sir, one patient is there. I have injected Botox for her 6 months before. He is a sister.
Endoscopically.
Endoscopically.
Yeah.
She is a sister of one of my teacher.
Ah.
So right now again she is having some problem.
She improved with Botox.
Improved, but not very significantly. Though I have done under vision.
Yeah.
Not from external, but through the endoscope.
Okay. Okay.
So I just want to show you.
Yeah, please.
We will do the endoscopy.
Yeah.
Dr. Sanjay Agrawal, our time schedule is up to 2 o'clock. I think we are going to finish at right time 2 o'clock because we have left few patients only. But 2 o'clock we will break. Then subsequently we will go to the hotel.
Sir has just gone out, I'll tell him.
Okay. We will stick to the schedule. Bring the patient. लाइए उनको सिस्टर कहाँ है?
हाँ सत्तू।
No, I am telling you that we have allotted till 2 o'clock laryngology workshop, so we will finish at 2.
सतपति साहब इज सीन।
हाँ, because आइए बैठिए।
नहीं तो तीन चार लोग बचे हैं।
हाँ बस 2 बजे खत्म हो जाएगा।
हाँ तो लंच का बोल देता हूँ। रेडी करा दूँ?
हाँ हाँ बोलिए, आपका नाम बताइए।
मेरा नाम प्रतिभा मिश्रा है।
कहाँ रहती है?
रायपुर में रहती हूँ।
She is coming from Raipur.
आपके पति का नाम क्या है?
मेरे पति का नाम प्रमोद चंद्र मिश्रा है।
आपके भाई का?
डॉक्टर दिव्य किशोर सतपति है।
ये प्रॉब्लम आपको कब से है?
1 साल हो गया।
मैंने जब पिछली बार आपको इंजेक्शन लगाया था, कितने महीने पहले लगाया था?
6 महीना।
जब इंजेक्शन लगाया तो उस समय कुछ आपको इम्प्रूवमेंट लगा था क्या?
थोड़ा हुआ है।
Some improvement. Okay.
थोड़ा सा।
Yeah, but no other breathing problem, no eating and drinking difficulty.
बाकी कोई भी आपको सांस की तकलीफ नहीं है?
सांस की नहीं है, लेकिन बात करती हूँ तो थकावट लगता है।
She has fatigue. Any other illness? High blood pressure?
Diabetes, blood pressure?
नहीं।
Nothing. Ask her to do the MPD.
एक लंबी सांस लेके बोलो।
As long as can.
अच्छा।
17-second MPD is quite good. That is typical of an spasmodic dysphonia. Now count 1, 2, 3. 1,
2, 3, 4, 5, 6, 7, 8, 9, 10.
Okay, can you count in English? 1, 2, 3.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Now block your ear with your finger. 1 ear block. Count. 1,
2, 3, 4, 5, 6, 7, 8, 9, 10.
Not much difference. Now with a baby voice, like एक दो तीन.
1 2 3 4 5
See that falsetto always, almost invariably, always abolishes the spasmodic dysphonia. So increased MPD, spasm, and better with the falsetto. So they all are signs of adductor spasmodic dysphonia. We'll do the scoping. Strobe. Spray, you need to spray.
Hello.
Yeah.
Sir, I just want to know, is there any element of dystonia also?
Is there
She
any-
has neck movements while talking.
Yeah, usually all these people will have some additional dystonias of the neck or the face muscle. She has got forcing, but that may be also due to the forcing of the voice. You can see again, count 1 to 10, 1, count 1.
3 4
You can see that there is some amount of spasm here. Can you see on the chin also, lower border? Ek, do,
Yes,
teen.
sir.
See that? The mandibular, yeah, oromandibular dystonia is common.
Mandibular dystonia.
Yeah,
there,
that is
sir.
when it is combined with blepharospasm, you call it Meg syndrome. Jelly.
Is there any possibility we'll get laryngeal tremors also in this case?
Yeah, you have to always rule out in like that. But here the point against is that laryngeal tremor doesn't always have a poor MPD, and they don't get better with falsetto, and they will generally have other tremors. Open hand. Nothing like that. It's unlikely that she has got a tremor.
I think even Parkinson people have laryngeal trauma.
No need to keep the mouth
आराम
lit.
से सीधा आगे झुक के.
Cool down.
Sir, endoscopic picture we are not able to see. Thank you, sir.
Keep the endoscope. No, ask. Are you getting it now? Hello?
Yes, sir. Yes, sir.
Breathe through the nose now. Breathe through the nose. Ask her to swallow. Swallow. Oh, that is enough. Enough. Don't swallow too many. All right. Straw bone. Okay. Ask her to say continuous E. Can you see the spasm there? Extraordinary spasm there is. And mind you, this is mainly from the lateral to medial. Do that. Oh, severe spasm. And ask her to say baby voice. Ee. See that there is no spasm, very minimum. Ee. Once again. Ee.
Very nice, sir. Very nice.
Okay, that's all. So again, standard option, 3 options, no treatment, Botox, surgery, whichever is up to them.
I think we will put her Botox once more.
Yeah.
And we'll show. This time what we will do endoscopy also as well as from external. So she will lie down here or she will do externally.
Lie down.
Okay. हटाओ ये सब चीजें. इस पे लिटाओ. लाके मैडम को ढको शॉल से.
Sir, what surgery you suggest in this case?
There are many surgeries, but the 2 standard surgery now available is, what I will prefer is always what is known as a SLADR, that is selective laryngeal denervation renervation. Where you do is identify the nerve to the thyroarytenoid by cutting a window on the thyroid cartilage bilaterally, cut it and then connect ANSA to it. That is known as a SLADR. That is more a physiologic surgery. Then there is an endoscopic surgery known as the endoscopic thyroarytenoid myoneurectomy. Either with the coablator or with the laser you can do that. That is not a very physiologic surgery. What you do is you take away 50% of the thyroarytenoid muscle with the laser or the coablator, so that over-adduction will be absent. So right now my policy will be that I will actually prefer always, first time I will always tell that you get Botox. And if patient is comfortable with Botox, I will not force them for surgery. If they are not comfortable with Botox, tell that, if you are, especially you are a young patient, will go for surgery. My first choice is always external surgery. If it fails, usually it has got a success rate of around 80%. If it fails, success means more than 2 years, there is symptom-free period. If it fails, then you go for the reserve endoscopic surgery. But people who are very particular, I have operated on singers, not singers in a dance, and they told that I don't want a scar. In that case, first choice will be an endoscopic thyroid node myoneurectomy. But otherwise, it is external surgery is the preferred choice. Type 2 thyroplasty was done earlier. Nowadays, it is almost forgotten, very hardly ever done. Only advantage of type 2 thyroplasty is that it is the only reversible operation in the spasmodic dysphonia. So if a singer comes, is very particular, very anxious, I may do that. But nowadays, I hardly ever do that. I need a small sheet, extension, small extension. Small extension. Can you get that, madam? Lift. Okay, lie down. So I am going to mark the cricothyroid space. Pen. So palpate the thyroid, palpate the cricoid, and in between, this is the cricothyroid space. So mark the midline. That's a midline, and 30 degree from the baseline is the direction of the vocal cord. So like, so this will be the direction of the vocal cord. I will first give the 4% silocaine. 4% silocaine. Tell her that this is a swab. Tell her that when I inject, she will have a small, little bit of cough. After that, the cough will suppress. So this is the 4% silocaine. I am just going to inject here. So you go perfectly perpendicular. Aspirate. Make sure that you are in the larynx, so air will come. And once you are there, you just inject there. So go like that. Yeah, that is inside. See that she is already coughing. That's all. Now press it for a minute, because there is no need of a hematoma shouldn't happen, because from the anterior jugular vein may be very, very close. So if a hematoma happens, then a Botox injection becomes very, very difficult, because the distance between the skin and the thyroid cartilage, if it becomes bigger, then the needle cannot be bent inside the larynx. So avoid hematoma always. So even if she doesn't have a hematoma or anything, press continuously for a minute at the site of injection. So you want to do a scopy now, or shall I do whatever way you want? Yeah, I will put the scope also. Okay, do that.
Yeah, please do scopy, sir, so that you'll be able to.
Yeah. So take Botox in an injection needle. Yeah. Okay. It's 27 gauge needle, the small needle, that red needle, yeah. Yeah, you can see the needle just entering the subglottis. Then it go underneath the vocal cord. Okay. So I think the position is important. How you stay there? I think the screen has to come here. No, it will not be there. It will not be possible. You have to come there, and the screen has to come at the head end. Otherwise, you can't see it. Oh, right. You can see. You can see that. Okay, right. Is it, you are comfortable with that technique? Okay, great. And mind you, always Botox injection is more difficult in a lady than in a male. Male larynx is very big, so you've got lot of space to see. You're okay?
Swallow?
Yeah, that's okay. Right, so I'm going to inject perfectly exactly in the same place. Can you see that needle there? It has gone subglottic, submucosally. Can you see that?
Yes, yes.
On the left side, can you see that? So that
Yes, sir, yes. Sir, it is on the right side, no?
yeah, right side, right side,
Right side.
right sir.
Right, right, yeah.
See, and now turn the needle upward and laterally, and it will actually go underneath the surface of the vocal cord. So,
Sir, just for orientation,
yeah,
when you were examining sitting and now this is lying, so right left changes, na sir,
doesn't
position?
matter. You are starting from the head end. So this
No,
is
no,
this,
but just to orient us.
yeah, from the head end it is the right side. This is the your right side is the patient's right. So I'm just going here. So if I want, I can actually take again and head up, head up, head up. Yeah.
सर जो कहते हैं वो करवा दिया करो बस.
See that now need? No, it didn't come. That is gone up. No, so it's actually aspirating now. See that? See the needle now?
Yes, yes.
Now I tilt like that and go like this. Go and hit the cricod. Now this is the undersurface of the vocal cord. I inject half 0.2 cc. That side is over. Now I take again, come out here. See the needle?
Yes.
Now turn the needle in the opposite direction. See that?
Yes,
That's
Yes,
under-
sir.
Very clearly.
Now I inject. That's all. Okay?
Vocal cord, yeah.
Okay, that's all.
Oh, yeah.
Once your experience, actually you can avoid entering the lumen, like the first part I did, submucosally. You can then patient won't actually cough.
But I think by entering the lumen, the show was good, so that people have
It's
understood.
over, madam.
Once you
Over.
gone to the right and
Yeah.
again you gone to the
Right.
left. So it was very clear this time.
Okay?
Yes, sir.
Right, that's all.
Patient है क्या बाहर? I think we have the last patient, Dr. Sanjay. So we are well within time. माता जी को ले जाके वहाँ लिटा दो.
Okay.
So how much time is now? What time is now?
20 minutes, 1:40 now.
1:40. Okay,
20.
we have 20 minutes more with us. I think you are tired because you have not taken Dr. Jay Kumar. I
No,
think
no, I can
deserves
finish.
a big applause because
20
he has
minutes.
not taken anything. People are clapping for you, and
Yeah,
still you are.
Thank you.
हाँ हाँ आइए आइए आइए. अच्छा, she is a patient not exactly having the vocal cord problem. She speaks well, but she is having some stammering and some lisp is there. certain words, and very small tongue tie is there.
She's a teacher.
No.
I trade in stock markets.
Okay, okay.
So at times because of like nervousness or maybe my body posture or the back becomes tight, I'm not able to talk properly.
Yeah.
And at times the words they get stuck, like words starting with S or B. So this lips, it gets tight.
Okay. So she has got both the lisping problem as well as mild stuttering. Stick out the tongue out, tongue up. Doesn't look like a big tongue tie. Let me see.
Very small.
Stick out the tongue, tongue out. No, tongue is, no, going, no, don't worry. Tongue outside. I am not doing anything. You can see that it is well beyond the vermilion border. So that means the tongue tie is not significant. And the second indication for tongue tie is when it is a forked tongue, like a W shape. It is neither. So I don't think there is any indication for a tongue tie release in her. Okay. So two indications are: one, patient is unable to protrude the tongue beyond the vermilion border. Second is that they have got a forked tongue, like a serpent tongue, like because the tongue tie hold it like that. So these are the only two indications for a tongue. She has got more of that disfluency, that when she is getting nervous, the tongue goes back. Actually, there is nothing. No need of a surgery for her.
Okay, and what about the advice for her?
That's a speech therapy, disfluency therapy. That is not in my field. It's
Okay.
actually like, there is something on us. There is a software called a delayed auditory feedback, DAF, that they can buy from the WAGMI or so for some 15,000 rupees like that. So they can practice with that. So that's a very good technique, DAF.
DF.
Delayed auditory feedback, and a speech therapist can help them out.
Okay. आइए. ठीक है. So I will explain you. Come on Monday, and I will explain you, and I will help you out.
SP, what about that the other lady, that third spasmodic dysphonia, that obese person? That there is one more spasmodic dysphonia. Is she getting today, or she's not going to, she's not taking any treatment? You told we gave 3 options, no? That we injected twice, 2 people. There was one more person, that who had 1 injection, he told he didn't benefit. Is she doing anything? There was a third spasmodic dysphonia lady.
Yeah, lady is there.
Yeah.
I mean, we have promised
Explained
her.
all those things.
Explain, and I told her that if you want, we can give you complimentary injection this time.
Up to them.
Up to
Okay.
them.
Okay.
They are deciding, and they will
Right.
let you know. Is there any more patient? So I think we are finished with all the patient, Dr. Sanjay Agrawal. So we will be moving from here, and we are coming
Yes,
here.
you come over.
Okay. Meanwhile, you can start lecture of, I think lunch break is there, no?
Lunch break. Ravi is taking rest. 2
Okay.
o'clock he will come.
Okay.
Devi's talk is there at 2 o'clock.
Ravi's talk is there.
Okay, so we
2:30.
can.
So yes, we can.
Thank you.
disperse. Thank you very much.
Thank you very much, sir, from all of us. Now, for the chairpersons, we would like to felicitate.
Kindly facilitate them.
So I invite Dr. Shrikant Phatak. And I would request Dr. Chauhan sir to please. Dr. Samir is here. Dr. Amit Ganguly and Dr. Sadat. Sadat, Amit Ganguly. Thank you. I don't see Amit Ganguly, Sadat and Samir in the hall. We'll just wait for one person has gone to bring them. Sadat is here, yes. So I request Dr. Mundra sir, please. So we break for lunch now and we gather dot at 2:30 with lecture of Dr. Ravi Ramalingam.
Recordings.